Hi everyone. So a very good evening to all of you, and it's good to connect with you again. And this time after a gap of 1 week, but it's always a pleasure to sort of get back and carry on these sessions. So I hope everybody is doing well, and you guys are busy preparing, doing duties, and managing a lot of things together. Yes? Okay. So just let me ensure that everybody is here. So if everyone can type a quick hi or a hello to your colleagues, it'll be great. Okay, so maybe a quick hi, hello in the chat box to your colleagues is a great way to begin the class. Yes? Okay. So hi Pranjita, hi Mansi. Good to connect with you. Okay, so I think today we have a fairly easy topic, yes, and I'm sure you all are a pro at it and you already know everything. So we will sort of refresh things up and have gone through the previous papers of FNB as well as NEET SS, where they are asking questions on bleeding in late pregnancy, and they're not very difficult ones. But yes, there have always been questions from this topic as well. So hi Dipanjali, Priyank, Neha. Good to have you back, Priyank. Priyank was not there, I think, in the last class. Huh, Priyank? How are you doing? Okay, hi Neha. So great. So everybody is here, and somebody is here silently, somebody is here proactively. It doesn't matter, as long as we are all in the class. That's great. Okay, so the pattern remains pretty much the same. We are going to discuss questions, and alongside we're going to talk about the particular topics. And if you have any doubts, you can just keep asking them side by side. Okay, so should we start? Is everyone ready? All right. So first one seems like a relatively longish question, but is not difficult at all. So yes, those are the new trends even for your SSN FMB exams, that they have or they are asking some of the longish questions as well. Okay, so let's look at this. Your patient is currently 31 weeks and she is presenting to labor and delivery suite complaining of vaginal bleeding earlier in the day that resolved on its own. She denies any leakage of fluid. Yes, and she denies uterine contractions. She reports good fetal movement. Okay, now in her last pregnancy, she had a low transverse cesarean delivery, but that was done for breech presentation. She denies any medical problems. Vital signs are normal, fetal heart rate monitoring is normal, and there are no contractions. Which of the following is the most appropriate next step in the management of this patient? Yes? Hi Sandy. I know, I understand Priyank. Duties is what obs and gynae is all about, right? So it's always going to be busy, but it's very, very satisfying as well. So what are we going to answer this as? So this is a patient who is in the 3rd trimester and is presenting to us with history of vaginal bleeding. Yes, so she's in the 3rd trimester with history of bleeding. So we are talking about antepartum hemorrhage. And although the bleeding has resolved now, we want to ask you, what are you going to do next? So do we want to send her home since the bleeding has completely resolved and she's experiencing good movements? No, right? Do we want to perform a sterile digital examination? No, right? There is absolutely no indication to do an amniocentesis in this patient, as well as a per speculum examination. She is denying any leakage of fluid. So I'm sure we all understand this is a very basic question that I wanted to start with. So no matter that even if the bleeding has stopped, you're going to perform an ultrasound examination. Can you please tell me what condition are we dealing with here? What is the likely diagnosis? So the likely diagnosis is going to be placenta previa. Yes, but can you tell me what are the key things that are telling us that this is placenta previa? So this is a patient who's presented to us with painless bleeding. Yes. So she is presenting to us with painless bleeding. That is the first thing. The second indication is she is a case of previous cesarean section. Yes. So she is a case of previous cesarean section. And the bleeding currently has resolved on its own. So we all know that in placenta previa, there are these warning hemorrhages. Yes. So this is a classic history of placenta previa, where women might have initially small bouts of bleeding that will resolve on its own. So warning hemorrhages are seen in placenta previa, right? So that is why we are thinking of placenta previa in this particular patient. Also, whenever a patient comes with antepartum hemorrhage, yes, so please remember, when we say APH, you know that we are going to do what? We are, as a definition, we say bleeding from or into the genital tract beyond the period of viability. Yes, so what is the period of viability in India? What is the period of viability? So please remember, there is no change in definitions of period of viability in India. So it is 28 weeks. So for us, or our Indian textbooks would say APH is bleeding from or into the genital tract beyond 28 weeks. But if you go to standard international textbooks, they will take it as any patient who comes to you with antepartum hemorrhage beyond 20 weeks, you should definitely keep placenta previa in your mind. Okay. Now, so any patient who comes to us with APH, what should be the first investigation that we would do? It is going to be ultrasound. But what I want to ask from you here is, which ultrasound do you want to do right now? So let's go on to the postgrad level, right? So what ultrasound do we want to do here? So when I say first investigation is ultrasound, so please remember the first ultrasound would always be a transabdominal ultrasound. Yes, so it's going to be a transabdominal scan. But in case the question asks you about investigation of choice for abnormally located placenta. Yes, so if they ask us investigation of choice for abnormally located placenta, then it has to be a TVS, right? So the IOC for placenta previa is transvaginal ultrasound, right? Now, please remember, whenever, we are doing TAS, and in TAS, any patient where you see placenta in the lower segment, all these patients who are showing us the placenta in the lower segment must undergo TVS. Okay, so this is to know exactly that what is the relationship of placenta with the internal os. So all these patients who show us previa on transabdominal scan must undergo a TVS. So yes, Priyank and Dipanjali are right. The first investigation is TAS, but investigation of choice is going to be TVS for placenta previa. Okay, now although we are saying that placenta previa is painless bleeding, I want to ask you, is it possible that a patient of placenta previa can have pain? Yes or no? Is it possible that a patient of placenta previa will also have pain as the presenting symptom? So yes, this is also a possibility. So please remember, 10 to 20% of patients with placenta previa. Okay, so 10 to 20% of patients of placenta previa can have pain. And usually these are the women who are going to be in labor, right? So this is going to be basically pain of uterine contractions, right? So yes, it is a possibility that there is going to be pain as well. Okay, the other relevant thing which I am very, very fond of asking you now, so what carries the highest risk of placenta previa? Yes, so if we talk about highest risk of placenta previa, right, what would you answer it as? Hanji, what would you answer it as? Okay, just a moment. I'm just trying to go through all the comments. Yes, so when we ask the highest risk, what is going to be the highest risk for placenta previa? Anybody? So this is patients with previous cesarean section. Yes, and we should know that the number of cesarean sections, when they keep increasing, the possibility or risk of placenta previa also keeps increasing. Yes. So, we say that with previous one cesarean, the risk can go up to 47%, right? So this is with previous one. And in case your patient has previous two, then, right, the risk will go even further. In some studies, they say even up to 60% risk after previous one placenta, after previous one cesarean section. So yes, that carries the highest risk. Can you also tell me what other is a very important risk factor? So please, मेरे बच्चे याद रखना कि whenever you are getting questions on antepartum hemorrhage, especially placenta previa or abruption, risk factors is definitely one of the MCQs. Yes, they are very fond of asking these things. The questions are not really difficult, but yes, they are asking risk factors for both previa and abruption in almost all exams, even in your super specialty exams. Okay? Yes, the other important risk factor is, apart from previous cesarean, the second thing that I definitely want you to remember is going to be multifetal pregnancy. Yes? So please remember, multifetal pregnancy also has a significantly high risk of placenta previa, and the risk can be as high as 40% in twin pregnancy, and it can be even higher in, higher order gestation. So with multifetal pregnancy, the risk of placenta previa is 40%. The third important risk factor, which in fact you have highlighted in the chat box as well, is absolutely yes, a past history of placenta previa, right? So it has a significant high recurrence risk as well. So anybody who can tell me what is the recurrence risk? What is the recurrence risk of placenta previa? So this ranges between 4 to 8%. Okay? So recurrence risk ranges between 4 to 8%. Okay? Now I want to know from you, कोई ऐसी condition पता है which has a negative association with placenta previa in pregnancy? Yes. So since I'm talking about risk factors, I want to talk about the opposite part as well. Right? So I'm not saying it's protective, but I want to ask you anything that you can recall right now which has a negative association with placenta previa. Does something come to your mind? Yes. So please remember preeclampsia. Okay. So preeclampsia and placenta previa have a negative association. So generally we say if there is a placenta previa, you would not see preeclampsia, right? We're not saying it's protective for preeclampsia, but it has a negative association. Okay. Then something that doesn't strike us usually in the exams, but we are often fond of asking, what about infertility treatment? Is it a risk factor? Yes or no? So yes. So please remember, infertility treatment or assisted reproductive techniques are also risk factors for antepartum hemorrhage, right? So they're also going to be risk factors for antepartum hemorrhage. So these are some of the very, very important risk factors that you should know when we talk about placenta previa. So on this note, before I go any further, okay, I think I might have a question. Do I have another question on risk factors? No. Okay. So let's talk about this. Now, what about relationship between placenta previa and, parity? So Priyank, nahi beta, IUGR is quite often seen with placenta previa. So kya hota hai? If they do have these multiple bouts of bleeding, these women may turn out to be anemic as well. And therefore, you are or you can see IUGR with placenta previa. एक और condition में मैं बताऊंगी Priyank, IUGR कहाँ पे linked है to placenta previa as we go further. अभी नहीं, because फिर MCQ करने का मजा खराब हो जाता है, but I'll tell you. Right? So anything that you can tell me about parity and placenta previa, which is again repeatedly asked in the exams. Anything that we want to talk about that? So Yes, please remember increasing parity. Okay, so increasing parity, increasing maternal age. Right, so these are also risk factors for placenta previa, right? So increasing parity, increasing maternal age. What about uterine anomalies? So yes, so congenital uterine anomalies can also increase or can be risk factors for placenta previa. What about smoking? What is the association between smoking and placenta previa? So smoking is also a risk factor for placenta previa, right? So these are some of the important things that we tend to ask whenever we ask questions on risk factors. Okay? Okay, great. Let's go further and let's look at the next level of the question. So the next one says, all the following are typical features of placenta previa except. So we already talked about painless bleeding. So yes, 80 to 90% of times it is going to be painless bleeding. So this is a true statement. First episode of bleeding is self-limited. So this is also a true statement. I told you that placenta previa is likely to have warning hemorrhages. है ना? Then may be associated with post-coital bleeding. Is that true? Yes. So this is also a true statement. So majority of times whenever we ask a patient of the reason or what she was doing before she had hemorrhage, majority of times you're not going to find a cause, right? But yes, postcoital bleeding coitus can be one of the reasons why she could bleed from the placenta previa. Is it commonly associated with coagulopathy? No. So we all know that when we talk about coagulopathy, we are going to more talk about abruption. और आगे बात करेंगे as we go further. So then we will talk about abruption. But just talking about the other side of the statement, can we see coagulopathy in placenta previa? Yes. So it is not commonly seen, but it can be seen. So we all know that if there is any time a massive hemorrhage, it can eventually lead to coagulopathy. So coagulopathy can be seen with both, but it is far more commonly seen with abruption as compared to placenta previa, right? So the answer here is going to be coagulopathy. Okay. Now, when we talk about, those were most of the characteristic things, and I think you've all got it right. That was an easy one as well. Now, there are certain things we want to know when it comes to the management aspects. Okay. Now, so this is again important. I will tell you various places and how they're asking it. So in placenta previa, which of the following statements is true? Is it common in primi gravida? No. So we just did that. So as I said, ki risk factors, ye log bar bar पूछते हैं in indirect form. So it is not common in primi, it's actually common in multigravidas. Yes. May cause abnormal lie. So this is true. So now again, this is something that I wanted to highlight. Whenever you talk about malpresentations, so malpresentations can definitely be seen in both. They can be seen in placenta previa, they can be seen with abruption. So yes, there is a higher risk of malpresentation, but if we have to ask, malpresentation किसमें ज़्यादा common है, then it is definitely placenta previa, right? So malpresentation is more common with placenta previa. Which malpresentation is specially linked to it? So typically if we have to answer, it is going to be transverse lie. So this could be asked as a labor question as well. For example, they will ask you, what is the most common cause of transverse lie in general? So in general, we all know that this is prematurity. Yes, so that is in general the most common cause of transverse lie. But when we say the most common cause of transverse lie at term, so then please realize that we are already ruling out prematurity. So when it comes to at term, it is going to be placenta previa. The same question can be asked as an applied MCQ as well. वो कैसे? A woman comes with transverse lie at term to your antenatal clinic, right? What are you supposed to do next? Always do an ultrasound, right? Before you do a PV exam or pelvic assessment. Take care. So always do a ultrasound when you are seeing a patient with transverse lie, because placenta previa is a very, very common thing to be associated with it. Okay. Now, if I ask you more about per abdomen findings in a patient with placenta previa, so what are the significant per abdomen findings in a patient with placenta previa, which we could put as questions or as hints in the question, right? So, majority of times the fundal height is going to be same as the period of gestation. Okay, but can fundal height be less than POG in placenta previa? So I'm asking you, can fundal height be less than the POG in placenta previa? The answer is yes, right? So this is a possibility as well, but it is never going to be more than the POG. Now, if we ask you what is the reason for fundal height less than POG? So one of the major answer here is, again, the reason is a frequent association with transverse lie. The second reason is IUGR. So जैसे मैंने अभी बोला था, there are one of the explanations for IUGR here is anemia. So multiple bouts, they can lead to anemia as well, and then IUGR can be a probability. There is a second reason as well, which I will further tell why you see it with IUGR, or you can see IUGR here. Then, what is the typical feel of the uterus on a PA exam? So we say the uterus is relaxed, yes, and it is non-tense. So it's very essential, because these are the key ways how we will differentiate it or placenta previa from abruption. Yes, so it is a relaxed uterus, it is non-tense, the fundal height is either same or less. Now I want to ask you, fetal heart rate abnormalities. Yes, so fetal heart rate abnormalities, are they more common with abruption or are they more common with placenta previa? So this you will again see very often as a statement in the APH questions. So fetal heart rate is frequently abnormal, or fetal heart rate is usually normal. So fetal heart rate abnormalities can happen in any APH, but are they more common with abruption or are they more common with previa? So yes, the fetal heart rate abnormalities in general are more common with placental abruption, and usually the FHR would be normal in cases of placenta previa. It can be abnormal, so if the bleeding is really heavy, even the FHR here can be abnormal. Yes, but generally more abnormalities are what you see with abruption, right? So those are the typical findings on a PA exam that would help us differentiate. Okay, perfect. It causes recurrent painful bleeding. So the word recurrent is true, but painful is false, right? So this is going to be a false statement again. Patient should be induced with prostaglandin. So this is again false. So as a matter of fact, now अभी हम आगे बात करेंगे. So या यहीं पे कर लेते हैं. We've already talked about that the investigation of choice is TVS. Now can you tell me what terminologies are we currently using for placenta previa? So there are only two terms now that we are using. So on the transvaginal ultrasound, we are going to classify it as either placenta previa, or we will classify it as low-lying placenta. है ना? So the older classifications of type 1, type 2, type 3, type 4 are no longer clinically used. So we are only using two terminologies. Either it's placenta previa or it is low-lying. So quickly tell me, what is the criteria to say it is low-lying? What is the criteria to say that it is a low-lying placenta? So we say when the placenta is within how much centimeters of the internal os? So when the placenta is within 2 centimeters of internal os, right? So when it is within 2 centimeters of internal os, then you say it is a low-lying placenta. So now for all practical reasons, once you say it is placenta previa, it means you're not going to do a vaginal delivery, right? So now the moment we say it is placenta previa, the management eventually has to be a cesarean section. Okay, you cannot deliver them vaginally, right? Can I ask you more details? Very good. Within 2 centimeters, perfect. Can you tell me, in low-lying placenta, can we do vaginal delivery? Yes or no? So can we do vaginal delivery? So yes, in low-lying placenta it can be done, but it is a very specific criteria. So we say in low-lying placenta, if the placenta is within 1 centimeters of internal os, then you should not be doing a vaginal delivery. This has to be delivered by a cesarean. But if it is more than 1 centimeters but less than 2 centimeters of internal os, so which means between 1 and 2 centimeters, this is where we can consider vaginal delivery, right? So only in a specific type of low-lying placenta can we go ahead with a vaginal delivery. Otherwise, the general answer always remains as cesarean. So unless they are being very specific about it, please don't answer it as vaginal delivery. We are going to answer it as CS. Perfect, Priyank. Very good. Okay, so those are important things when it comes to why TBS is so important, because we want to know the exact distances. Okay, now right, so we know that the answer here is B, which is may cause abnormal lie. Okay, now let's go further and then I'll bring in more points. Now in the management of placenta previa centralis, so although this is no longer a term, but this is a previous year SS question. Okay, so centralis आजकल हम use नहीं करते. So centralis typically means a type 4 placenta previa or a central placenta previa in the older classification. Yes. So can you tell me the answer for this? Once the diagnosis is made, the treatment should be urgent cesarean. Is this true? The answer is no. Yes, so this is not true. This is a false statement. Okay. Patient may stay home if she is living near the hospital. So no, again, this is not true for a central placenta previa. Okay. Vaginal examination should be done carefully to confirm diagnosis. Again, a false statement. So PV examination should not be done once we already know that it is a central placenta previa. And the answer here becomes D. If the patient is advanced to 37 weeks, it is usually best to perform a cesarean section. Yes. So that is the answer here. So whether you do a cesarean or not depends on at what time do you do it, depends on the clinical presentation of the patient. अच्छा, मुझे ये बताओ, generally planned cesarean section for placenta previa is done at what POG? So at what period of gestation are we going to do a planned cesarean section for placenta previa? So the guidelines say anywhere between 36 to 37 plus 6. But so since these are international guidelines, the common thing that we follow for especially answering MCQs is 37 weeks. So once placenta previa reaches 37 weeks, we do not continue the pregnancy any further. We would simply be doing a elective cesarean section. Yes, once she reaches 37 weeks. Okay. Now, okay. Right. So let's look at the next question now, so that I'm able to link it to other things as well. Okay. Yes, Asha is right. Uncomplicated and reaching as I said, the international guidelines are 36 to 37 weeks. Okay, now let's look at this one. So she is a patient who is 28 weeks and she is presenting to us with complaints of bleeding. Vital signs are stable. Okay, she denies any contractions and the baby is moving normally. The placenta is anteriorly located and completely covering the internal os. So this is what the previous question was also about, a central placenta previa. Yes, so a central placenta previa. But currently she is 28 weeks. Okay, and she has come to us with antepartum hemorrhage. Question बोल रहा है, which of the following would most likely increase her risk of hysterectomy? Yes, what is the answer for this one? Now पहली चीज है, although she is 28 weeks and she has come to us with bleeding, is it an indication to take her up for a cesarean section right now? So that is the first thing I want to talk about. Is this an indication of taking the patient up for a cesarean right now? So the answer is no. Okay, she is 28 weeks. The mother is stable. Yes, right? So the mother is stable. The fetus is stable. So as of now, there is no indication to do a cesarean section for this patient. So she is an ideal candidate for what? She is currently an ideal candidate for conservative management. Yes. So as of now, she is a candidate for conservative management. Quickly tell me, what is the name of the management that we follow? So Johnson's and McAfee's regime. Yes. So Johnson's and McAfee's regime is what we follow as conservative management. Now let me ask you, can you give, okay, tocolytics in placenta previa? Yes or no? Can you give tocolytics in placenta previa? Yes or no? So the answer is yes. Okay, so tocolytics can be given. The indication remains same, which is preterm labor. So if there are documented contractions, yes, so if there are documented contractions, and if my patient is less than 34 weeks, yes, then yes, I can even give her tocolytics. Now these are some contrasting things that I want to highlight because that's how the management of previa and abruption vary as well, right? So you can give tocolytics in placenta previa if required, okay? Then, should we give Magself to this patient right now or no need? So should we give Magself or no need? Yes. So please remember, Magself is to be given in these patients where the pregnancy is less than 32 weeks. Okay, so where the pregnancy is less than 32 weeks and there is a possibility that you might have to do an urgent delivery, we will give Magself, and this is for neuroprotection. So maybe, you know, in the exam, you get a question on the management aspect, whereas what all are you going to do with this patient? So we will give her Magself. We can give tocolytics if there is an indication. What about steroids cover? Should we give her a steroid cover? Yes. So please remember, now it is recommended to give steroid cover up to 37 weeks. So especially where you know that you're going to deliver the patient by cesarean section and it can happen any time. Yes. So steroid cover can be given up to 37 weeks. Yes. So tocolytics can be given. We will give her Magself. We will give her steroid cover. So those would be along with fetal monitoring and maternal monitoring. So those would be the key components of her conservative management. Okay. Now I want to ask you. So yes, let's go back to what this particular question is asking. So this particular question is asking, which of the following would most increase her risk for hysterectomy? So yes, the answer here is C, okay, which is placenta accreta. So you all answered it correctly. tell me what is the association. So please remember that in all patients with placenta previa, we said one important reason for doing the ultrasound was to know the exact distance between placenta and the internal os. Right? Then we said another important indication to do the ultrasound is to know the lie of the baby. Yes, so if it's transverse, we want to confirm it. The third important indication why ultrasound becomes very important in a patient of placenta previa is to look for PAS. Yes, is to look for PAS, placenta accreta spectrum. Now let me ask you this. Can you tell me what is the ideal time for ultrasound to look for PAS? Yes, what is the ideal time for ultrasound to look for placenta accreta spectrum? So, किस टाइम पे सबसे अच्छा होता है ये अल्ट्रासाउंड करना, right? So the ideal time is going to be 18 to 24 weeks. So that is the time when we want to look for PAS, right? Now, taking this further, on the ultrasound, you can see many features which are suggestive of PAS. Yes, so you can see many signs. But I want to ask you, what are the two most reliable? Okay, so what are the two most reliable ultrasound signs of PAS? So please remember, even if they ask you investigation of choice for PAS, the answer remains as ultrasound. You can add Doppler to it as well, but in general, the IOC remains as ultrasound. So what are the two most reliable signs on ultrasound which tell you that the patient is having a placenta accreta spectrum? Anybody? So, yes, anyone who wants to tell me which are the two most reliable signs? So the first one is seeing of placental lacunae. Yes, which we also call as intraplacental lakes, right? So placental lacunae and intraplacental lakes. The second very reliable sign is disruption of bladder line. Okay, the second most reliable sign is, very good Asha, excellent, yes, disruption of bladder line, right? Bladder line kya hai? This is a clear space which is generally present between the uterine serosa and the bladder wall. So this clear space is disrupted. So we say disruption of bladder line. These are the two most reliable signs which should make us think of, placenta accreta spectrum. Now, taking it further, which patients will have highest risk of PAS? Okay, so which patients will have highest risk of placenta accreta spectrum? So, ये कब होगा? ये तब होगा when there is a combination of a current placenta previa in my patient along with a previous cesarean section. Yes. So tell me which type of cesarean. Again, if you just have to make choices more difficult, the risk is higher with classical cesarean, or is the risk higher with with lower segment? No. So Priyank, MRI is not the IOC beta. MRI is not in fact required in all the conditions of PAS. MRI is only required if ultrasound is not sure to give the diagnosis. Okay. And second, if we want to know the exact depth of invasion bache. Right. So MRI is not considered the IOC. The IOC is ultrasound bacha. Okay, Priyank? Okay. So IOC remains as ultrasound, and as I said, you can very well add Doppler to it because they come in the same machine. But MRI is only done in certain specific conditions of PAS. For example, if you have an evidence that you're dealing with a percreta, then yes, it's a good idea to do an MRI to see the further extent of spread. Okay. Yes, so you can call it a gold standard, definitely. It will give you all the other details that you need to know, okay? So the highest risk is with current placenta previa and previous cesarean. So now I'm asking you, is the risk higher with classical cesarean or is the risk higher with lower segment? So please remember बच्चे, ये एक catch है. Normally बुरा कौन सा cesarean होता है? Classical वाला, है ना? मगर यहाँ हम बोल रहे हैं adherent or placenta accreta spectrum. Yes. So here the risk is higher with the lower segment cesarean. क्यों? देखो accreta कब होगा? Accreta, increta या percreta कब होगा? When the placenta is in the area of the scar. Yes. So अगर scar नीचे है, okay, and placenta भी previa है, then the risk is highest. क्लासिकल में क्या होता है? स्कार ऊपर है लेकिन प्लासेंटा नीचे है, सो देन इट इज नॉट गोइंग टू लीड टू पास, राइट? सो हियर द रिस्क टेंड्स टू बी हायर विथ प्रीविया व्हेन इट इज अ लोअर सेगमेंट सिजेरियन सेक्शन, ओके, नॉट विथ द क्लासिकल. ओके, जस्ट टू आस्क यू अनदर कंफ्यूजर हियर, इज प्लासेंटा प्रीविया अलोन? I mean, by alone, I mean there is no previous cesarean. So is placenta previa alone a risk factor for PAS? Is placenta previa alone a risk factor for PAS? The answer is yes. So please remember, cesarean section alone is not a risk factor for PAS, but placenta previa alone is also a risk factor for PAS. So now if somebody asks you, should you look for PAS in all patients of placenta previa? Yes or no? Yes. So I'm just trying to, these are certain things that come to our mind even as clinicians, right? So when you are sending a patient of placenta previa for an ultrasound, should you ask, or if it's a good radiologist, should they also look for PAS even in the absence of a cesarean? Yes. Okay, so please remember that. Even if there is no history of cesarean section, in all patients of placenta previa, on the ultrasound at 18 to 24 weeks, we should try and rule out PAS. Okay? Now, what is in general the management of PAS? What is in general management of PAS? Placenta accreta spectrum का management क्या है? So it is going to be a cesarean hysterectomy, है ना? So the general management is cesarean hysterectomy. At what POG do we want to do this? At what period of gestation do we want to do this planned cesarean hysterectomy? So here we want to do it a little earlier, right? So the guidelines say 34 to 35 plus 6 weeks. Okay, so that is the time when we would plan a cesarean hysterectomy for our patients of placenta accreta spectrum. Now, I want to ask you another confuser here. So you're first going to do a cesarean and then you're going to do a hysterectomy. What cesarean are you going to do here? So is it lower segment? Is it classical? What cesarean should you be doing for PAS when you're doing a cesarean hysterectomy? What cesarean do we want to do here? Yes, so exactly, Deepanjali, as soon as 34 weeks are crossed. So Priyank, less than 34 पे बहुत कम indications होते हैं बेटा where we want to do a elective cesarean. So 34 is a safer bet to play. Okay. So what cesarean? Very good. Excellent. Yes, Neha, Aparajita, as well as Priyank. Very good. So please remember, here we are going to do a classical cesarean. It's not a lower segment. Whereas in general, when you talk about placenta previa, the cesarean section we do is LSCS. It's not necessary to do a classical cesarean. You only do classical when you're not trained enough. Okay? But for PAS, the cesarean that you should be doing is a classical cesarean because you're going to cut the myometrium. So if you cut it in the area of PAS, you don't know when you will cut the placental tissue, and there will be a torrential hemorrhage because it's invading into the myometrium. So yes, we do a classical cesarean for that. Okay, perfect. So let's look at the next question. So you have a 22-year-old woman who is noted to have a marginal placenta previa. So as per the older classification, marginal was type 2. Yes, so marginal in the older classification was type 2. On ultrasound at 24 weeks, which of the following is most appropriate management? So what is going to be the answer for this? So are you going to schedule a cesarean at 38 weeks? Are you going to schedule first an amniocentesis to look for lung maturation and then do a cesarean? Are you going to reassess the position, or are you going to do a termination of pregnancy right away? So क्या करना है? So I'm sure ये सारे आप लोग, मैंने बोला the topic is not difficult. So I'm sure you know answers to every question that I'm going to give you. The idea is just to do a fruitful discussion as well. I have tried to take the previous year questions from both the FNB and the NEET SS exams, wherever I could collect them from, right? And these are the kind of questions they are asking actually, right? So absolutely the answer is C. You are going to reassess the placental position at 32 weeks. Okay. Now tell me, a lot of women, or I would just say that up to 6% of women can show placenta previa on ultrasound between 10 to 20 weeks. So early pregnancy may up to 6% women can show us a placenta which is in the lower segment. But what we need to know is that 90% of these cases are going to resolve, right? So 90% of these are going to resolve because of placental migration. So इसीलिए we must do repeat ultrasounds. कब कब करते हैं? So we should repeat ultrasound at 32 weeks. And then we should also repeat ultrasound at 36 weeks to look for a placenta which has not migrated. Now coming to further details. Can you tell me what are we going to see on the ultrasound which tells us about the likelihood of persistence? Okay. So what are we going to see on ultrasound which tells us the likelihood of persistence of placenta previa in a particular patient? Anybody? Likelihood of persistence of placenta previa कैसे देखते हैं? So for this, again, it is ultrasound, and that is why TVS is very essential. Why? Because we want to know the distance which the placenta is going over the internal os. So can you tell me that if the placenta extends, you'll fill in the you will fill the blank space for me. If the placenta extends more than dash over internal os, then the likelihood of persistence is high. Can you tell me what is the dash here? If the placenta, this is a very specific criteria which we are supposed to comment on the ultrasound. So if the placenta extends more than dash over the internal os, it means high risk of persistence. What is this value? So very important, if it extends more than or equal to 25 mm, okay, so the criteria is if it extends more than or equal to 25 mm over the internal os, okay, then we say that it has a high chance to persist. Okay, so yes, perfect. Okay, Right. So you must do repeat ultrasounds and try and see for placental migration. Okay? Okay. Now, I have to talk about certain more associations of placenta previa. So let's go on to a relatively bigger MCQ. Okay, so let's look at this. So your patient is 32-year-old. She's coming to labor and delivery at 30 weeks, complaining of a small amount of bright red blood, okay, which occurred shortly after intercourse. I'm highlighting the keywords because it's a big question for you, so that it becomes easy. Then it started off as spotting and then progressed to light bleeding. By the time the patient arrived, the bleeding had completely resolved. She denies any contractions but admits to occasional cramping, right? She had a normal ultrasound done at 18 weeks of gestation. Her history is significant for a previous lower segment cesarean section. Vital signs are normal, tocometer shows contractions, and the fetal heart rate tracing is reactive. Which of the following can be ruled out as a cause of her bleeding? So please read the question carefully. आपको बताना है, which of the following can be ruled out as a cause for her vaginal bleeding? Yes. What do you think is the answer? What is clearly ruled out? So the best answer here, what is ruled out is vasa previa. Yes? Can you tell me why? The answer is vasa previa. But why? How? Others can still be possibilities, but it's not going to be vasa previa. Yes, but why? What is the reason? So the reason here is a normal fetal heart rate. Yes, the fetal heart rate is normal. Not just that, the bleeding has subsided on its own. That is not something which will happen with vasa previa. So please remember, in vasa previa, unlike placenta previa and abruption, it is actually the fetal blood, right? Which is seen externally. So this actually leads to a very quick fetal exsanguination. And that is why we say that vasa previa is considered as an obstetric emergency. Yes, so it is considered as an obstetric emergency. Now, when I am talking about vasa previa, right, why are we talking about vasa previa with respect to placenta previa? Can you think? Why are we talking about vasa previa with respect to placenta previa? So, number one, it is a differential diagnosis. Okay, so it is a DD because both of them are going to present as antepartum hemorrhage. The second reason why we are talking about it is because they can be seen together. Okay, so they can be seen together. Now, there is abnormal umbilical cord insertions. For example, velamentous cord insertion. Yes, so there is a velamentous cord insertion. And this velamentous cord insertion is associated with placenta previa and it is also associated with vasa previa. So you can actually see them together as well. Okay. Now, this is why initially I said you are likely to see IUGR as well in placenta previa, and one reason I said was frequent small bleedings which lead to anemia. But the other reason for IUGR could be abnormal cord insertions. So please remember, velamentous cord is also linked to IUGR. It is also linked to preterm labor and therefore low birth weight. So very often they will ask you, what are the associations or obstetric complications that you could see with velamentous cord insertion. So the obstetric associations of velamentous cord insertion are placenta previa, vasa previa, both of which can present as APH. Apart from that, it is linked to IUGR and preterm labor. Right? Another reason for IUGR and velamentous is also very frequent, compression of the vessels. So here the vessels are not well or surrounded by the Wharton's jelly. They are not protected by the Wharton's jelly. So they are more prone to compression, which is also the reason why you have a higher association with IUGR. Okay? So those are the obstetric indications. Now, whether it is vasa previa or it is velamentous, again, the investigation of choice remains as ultrasound, right? So we say IOC is ultrasound if it is only velamentous, right? Whereas if they ask us about vasa previa, we should preferably answer it as ultrasound Doppler, right? Because this here we want to actually see the vessel over the internal os. So ultrasound Doppler together is a better answer for vasa previa. Now, do you know the criteria on ultrasound again? What is the criteria to say that it is vasa previa? So here we say vessels should be in close proximity. Okay, so vessels are in close proximity to internal os. मगर इसका भी मुझे क्राइटेरिया जानना है. What is the criteria? So we are saying close proximity, but how close is it required to say that it is vasa previa? So here again, the criteria is it should be within 2 centimeters of internal os. Okay, so it should be within 2 centimeters of internal os. What is a good time to do ultrasound Doppler to confirm that it is vasa previa or to look for vasa previa? So the good time to do this is 32 weeks. So 32 weeks pe ultrasound Doppler is the time when we want to look for vasa previa, right? And what is the preferred mode of delivery for vasa previa? So once you know that it is vasa previa, what is the preferred mode? So preferred mode is again going to be a elective cesarean. Okay, so and this is again preferably done after 34 weeks. So elective cesarean at 34, very good, Asha. Yes, so elective cesarean at 34 to 35 weeks is when we want to schedule an elective cesarean section for these patients. Okay? Right? So please remember how or what are all the things that we want to look for when we're talking about placenta previa and we're talking about ultrasound. Right? So vasa previa, velamentous are important things that we should look for. Okay? Chalo, excellent. Let's go further. Yet another, okay, this is something that I've already discussed. So vasa previa diagnosis in early labor is best treated with, right? So let's say this woman has already gone in labor, she's in early labor, what do we want to do for her? So this is best treated with, as we said, cesarean section. Yes. Now this is fetal blood. Can you tell me which test, okay, which test can help us differentiate fetal blood from maternal blood? Which test can differentiate fetal blood from maternal blood? Yes, so the preferable answer for this case is going to be APT test. Right, so the preferable answer is APT. Now, tell me quickly, APT कौन से तरह का test है? Is it an alkali denaturation test or is it an acid denaturation test? So APT is, yes, a alkali denaturation test. And then I want to know from you, is it a qualitative test or a quantitative test? So, is it qualitative or is it quantitative? So yes, this is going to be a qualitative test. right? So it's a qualitative test. What alkali are we using here? What alkali are we using here? 1% NaOH, right? So the most common one that is used is 1% NaOH, which is what we use in the APT test. It's a bedside test actually. Practically हम और आपने कभी ये किया नहीं है for antepartum hemorrhage, but yes, theoretically ये कर सकते हैं if you doubt whether the blood loss is fetal or maternal. Now यहाँ पे जल्दी से बस याद करके बता दो, we will not talk about that test here, we will talk about that test in Rh negative pregnancy, but can you tell me which is the other test which can help us differentiate between fetal and maternal blood? Yes, so that is Kleihor-Betke. So the difference here is that this is actually a laboratory test. It's not a bedside test. This is a acid denaturation test, not alkali. And it is quantitative. And the acid that we use is citric acid phosphate buffer. Yes, so citric acid phosphate buffer is what we use in the Kleihor-Betke test, and we all know that we use this in Rh isoimmunization. So we will talk more about that when we do Rh negative pregnancy, which would be included in the high risk pregnancy. Okay? Alright. So this is Vasa previa and management. Okay, let's go further. So again, this is something we have talked about. So velamentous cord insertion is associated with increased risk of, what will you answer this as? So torsion of the umbilical cord, fetal malformations, PROM, or fetal bleeding before labor. So now we know, because it has a strong association with Vasa previa, that is why the answer is going to be fetal bleeding before labor. So whenever rupture of membranes can happen, or even without rupture, there is a possibility that there is antepartum hemorrhage. Okay, majority of times it will happen with Vasa previa once the membranes rupture. Yes, so yes, it's just an applied format of the associations that we have done for velamentous cord insertion. Okay, let's look at this. So this is again a longish and an applied question. Let's see. So your patient is 31 weeks and she is a known case of placenta previa. She presents with vaginal bleeding. On assessment, she has normal vital signs and the FHR tracing also is normal. Okay. There are accelerations, no decelerations, no contractions. Heavy bleeding is noted. Which of the following is the best next step in the management of this patient? So what do you want to do here? So what do we want to do here? Okay, so are we going to give her a terbutaline here? So terbutaline, we all know, is a tocolytic agent, and here there is no indication as of now that we see to give a tocolytic agent. So I said you will only give it if there is threatened preterm contractions. Okay. Are you going to give her methergin? Again, no. Now, I am sure you already know that the answer is not induced labor because she is placenta previa. So what is the answer? Is it admit and stabilize, or is it perform a cesarean section? So since they're asking us the best next step. So that is how the AIIMS people or other places, when they talk about SSR also, they're asking questions. So it will be the next best step, right? So this has to be admit and stabilize the patient first, right? So you have to admit and stabilize. But if she continues to bleed heavily, then yes, we might have to take her up for a emergency cesarean section. Okay, but initially we just want to admit, stabilize, keep a check on the vitals, keep a check on the fetal heart rate. But as I say, if she continues to bleed heavily, then we might have to take her up for an emergency cesarean section. Okay? Chalo. Let's look at the next one. So this is Again, interesting, and let's see if you are able to catch this one. So your patient undergoes a spontaneous delivery without complications. The placenta is also spontaneously delivered and appears intact. The patient is later transferred to the postpartum floor where she starts to bleed profusely. Physical examination reveals a bogey uterus and a bedside sonogram indicates presence of placental tissue. What is the likely association of this clinical condition? Yes? What is the likely association of this condition? What is the answer for this one? So, this is going to be B. Placenta succenturiata. Right? So, this is placenta succenturiata. So, if you remember, in placenta succenturiata, there is a main lobe and there is a accessory lobe, right? And the umbilical cord is attached to the main lobe, and then there are vessels which are joining the main lobe to the accessory lobe, right? So this is what is succenturiata. So what happens is, if they ask you, can succenturiata be a cause of PPH? Yes. Okay. So succenturiata can lead to postpartum hemorrhage. How? Exactly like this. So what happens is, the placenta is delivered and it also looks complete. So the confuser here is that the placenta looks complete. Right? They may not say that the ultrasound is done. They may still say, they may omit those details and they will say the uterus seems bogey or atonic. What could be the possible cause? So, the accessory lobe is left behind and then it leads to postpartum hemorrhage. Now, I am sure you all knew that succenturiata can cause PPH. Now, they could actually form another clinical MCQ on the same lines and ask you, can succenturiata cause APH? Yes, tell me. Can a succenturiata cause antepartum hemorrhage? So we have seen it is very likely to cause postpartum hemorrhage, but can it cause antepartum hemorrhage? Yes or no? Hanji, yes or no? So the answer is yes. Now you're going to tell me how. How will succenturiata cause antepartum hemorrhage? Anybody? So as I said, that there is a main lobe and there is an accessory lobe, and then there are vessels which are joining the main lobe to the accessory lobe. Sometimes what happens is, when these vessels are going from main lobe to the accessory lobe, they will pass over the internal os. Right? So there is a possibility that while going from the main lobe to the accessory lobe, they will cross over the internal os. So yes, this could also be associated with vasa previa. So कई बार बच्चे गलती कर देते हैं. No doubt, vasa previa, if we ask you about which placental abnormality it has a high association, the answer is velamentous. So higher association is definitely seen with velamentous, but it can also be seen, very good Priyank, yes, but it can also be seen with succenturiata. So this can also lead to vasa previa. In fact, ये सब मिला जुला कर cause हो जाते हैं. Let's see how. A typical case would be like this. So if this is the uterus, right, cervix, internal os, placenta, main lobe. So now it is also previa. So it can also be associated with placenta previa. Here is the accessory lobe. And then these vessels are crossing. So yes, it can cause antepartum hemorrhage either because of the placenta previa or the vessels which are joining the main lobe to the accessory lobe. Right? So yes, succenturiata can also cause antepartum hemorrhage. Okay? Perfect. Okay. Let's go further now. Okay, so I try to keep a mix of longish and small questions. So let's look at this one. So your patient is 28 weeks. She is complaining of decreased fetal movements. She has had no prenatal care, and on the monitor there are no contractions. The fetal heart rate is 150 and reactive. Okay, there are no decelerations. An ultrasound is performed and it shows a 28-week fetus with a normal anatomy and size. The placenta is implanted on the posterior wall and its margin is well away from the cervix. A succenturiate lobe is seen implanted low on the anterior wall of the uterus. Doppler studies indicates vessel is traversing the cervix, right, connecting the two lobes. The patient is most at risk of which of the following? So this is exactly the same question that I was telling you, but I just wanted to say that, you know, the same things that we teach as concepts can be asked as one-liners, they could come as visuals, and they could come as long clinical questions. Right, so this is a typical question which is explaining the same thing that we discussed in the previous one. So what is the answer? The patient is most at risk for which of the following? Fetal exsanguination after rupture of membranes, right? So this is the likely reason why there is a possibility that the baby is going to be still at high risk, despite the fact that the FHR is normal, the NST is reactive, but still there is a possibility of fetal exsanguination. So it's the same question, just asked in a very, very clinical format. Okay? Okay. So let's move on to the second cause of antepartum hemorrhage. Now regarding abruption placentae, when it comes like this, you have to answer the correct statement. So these are some of the previous year questions, in fact. Okay. So regarding abruption placenta, which of the following is true? Okay. So whenever it is like this, you have to answer the true statements. So PPH occurs only when there is hypofibrinogenemia. Is this true or false? This is a false statement. Yes. Maternal anemia is a major cause of abruption. This is also false. Fetal heart rate is usually normal. I already discussed this. It's more likely to have fetal heart rate abnormalities. So this is also false. And therefore the answer is D, associated with antecedent hypertension. So जैसे मैंने पहले भी कहा था, that when it comes to placenta previa and abruption, they are very fond of asking risk factors. So what are the most important risk factors? So let me first ask you, what carries the highest risk? What carries the highest risk of abruption? इसका क्या आंसर है? So when we ask you about highest risk, it has to be previous history of abruption. Okay, so then it has to be previous history of abruption. Can you tell me what is the recurrence risk? What is the recurrence risk? So the recurrence risk after one previous abruption is 10 to 15 fold higher. Okay, so the recurrence risk is 10 to 15 fold higher. Apart from this, yes, hypertension in pregnancy is an important risk factor for abruption. The risk is 5-fold higher, right? So with women with preeclampsia, the risk is 5-fold higher. Okay? Then, what else apart from these two is an important risk factor? If you have to name a third important risk factor, what would that be? So the third important risk factor is trauma, right? Trauma to abdomen. So blunt trauma to abdomen is again a very important risk factor for abruption. Apart from this, polyhydramnios is a risk factor. Okay, so polyhydramnios is a risk factor. Prolonged rupture of membranes is a risk factor. Now, what about uterine anomalies? Are they a risk factor? So that's where the confusion is. So uterine anomalies, we said, is a risk factor for placenta previa. But what about abruption? So, yes, uterine anomalies are a risk factor for abruption as well. Okay, and this is usually because of the abnormal vascularity of the uterus. So very often, an anomalous uterus can have abnormal vascularity, and it can be a risk factor for abruption as well, apart from being a risk factor for placenta previa. Okay? Then, what about smoking? Is it a risk factor for abruption? So yes. So please remember, smoking in general we say is protective for pre-eclampsia, but smoking is actually a risk factor for abruption. Yes, it is a risk factor for abruption. So is cocaine abuse, right? So these two are again strongly linked to abruption. Okay? Now, as far as abruption goes, one other thing that I want you to know is thrombophilias, right? So thrombophilias of pregnancy are also risk factors for abruption. Yes, so thrombophilias of pregnancy are also going to be risk factors for abruption. Now, you know what is the classic presentation of abruption. So what is the classic presentation of abruption? So, okay, so let's do question number 14 first. So this is the one that we asked about risk factors. So which of the following carries the highest risk of the pathological process shown? So what you see here is a RPC or a retroplacental clot, and the highest risk we said is previous history of the same event. Okay, so previous history of the same event. Yes. So coming back to what I was speaking of is what is the, okay, so this is a previous year question, so that is why I've put it in the test paper as well, simply because it was previous year, but it is simple. The most common risk factors are going to be multiparity and hypertension. So just like placenta previa, please remember multiparity as well as increasing maternal age. They are also both risk factors for placental abruption. Okay, so they are also risk factors for placental abruption. Okay? Okay, so this question was not about, so one was about highest risk, but the one that has come as a previous year exam question was the most common risk factors. Now, when we talk about abruption, and I keep seeing a question. Okay, so tell me, what is the classic presentation? So we all know that it is painful bleeding. Yes? But now I want to know from you, when we talk about the classic presentation, what is the more commoner presentation? Is it pain or is it bleeding? So what is the most common presentation for abruption? So please remember, the most common presentation remains as bleeding. Please don't answer it as pain. Yes? Now majority of these patients are going to come to us with bleeding. But I'm going to ask you the reverse. Is there a possibility that there is abruption and there is no bleeding and there's only pain? Yes? Is it a possibility that there is no bleeding, but the patient only has pain as the presentation? So is that a possibility? Yes. So that is what we see in concealed hemorrhage. So in concealed hemorrhage, all the blood is collecting inside, so there is no external bleeding. But please remember, this happens in only 10 to 20% of patients. So 10 to 20% of patients may not have bleeding. Just like we said in placenta previa, 10 to 20% may have pain. Here we are saying 10 to 20% may not have bleeding and they may have only pain, but this is a much smaller group, right? Then the blood loss is also important here because some amount is collecting. Please understand these are the keywords we use. Bright red is a term they use for placenta previa bleeding, whereas altered or dark color. Okay, so altered or dark color is the term what they use with abruption. Okay, so Asha is asking what is more common, revealed or concealed. So I just said majority of times it is going to be revealed. Magar Asha ek aur category hoti hai, yaad hai, mixed. So in general the most common is mixed abruption. ठीक है? If that is in the options, you go with mixed. Mixed में क्या हो रहा है? Some amount is being concealed and some amount is being revealed. So this is in general the most common. But अगर mixed option में नहीं है, then you should definitely go and answer it as revealed बच्चा. ठीक है? So if the word mixed abruption, because ये older classification है, right? Revealed, mixed or concealed. So if mixed is not in the options, you should definitely go and mark revealed, which is what is the more common type. ठीक है? Now, the third way in how abruption clinical, okay, let me ask you this. So is abruption a clinical diagnosis or a lab diagnosis? Is abruption a clinical diagnosis or is it a diagnosis of investigations? So ये वाली चीज पे भी मैंने बहुत सारे प्रीवियस ईयर एमसीक्यूज देखे हैं, ठीक है, आपके नीट एसएस और एफएनबी के. सो इज इट अ क्लिनिकल डायग्नोसिस और इज इट अ investigation based diagnosis? So please remember, majority of times abruption is a clinical diagnosis, right? Why? Because when you talk about confirming abruption and you talk about investigations, then we know it is ultrasound. Ultrasound में क्या दिखता है? RPC, a retroplacental clot. But a majority of times you may not see a RPC. So primarily we say it is a clinical diagnosis. Ultrasound is not a very good modality to confirm abruption. ठीक है? फिर भी in all patients of abruption we are always doing an ultrasound. Why? So we are not doing it to actually confirm abruption, but we do ultrasound in all patients. Even if it is clinically abruption, we do ultrasound to rule out placenta previa. Okay, so ultrasound is usually done to rule out placenta previa, but it cannot rule out abruption. That is what I am trying to say. So it cannot rule out abruption. Yes, so because even if RPC is not there, it can still be abruption. ठीक है? So majority of times, yes, you're all right, Apurajita, Dipanjali, it is a clinical diagnosis. So there is a painful bleeding, that's the history. And what is the classical finding on PA exam? It is a tense and a tender uterus, right? So it's a tense and a tender uterus. Fundal height tends to be more than POG, and that's simply because some amount of blood is collecting inside. So that's a classic presentation. Fetal heart rate abnormalities are common, unlike placenta previa where they are less common. Fetal heart rate abnormalities are more common with abruption. So they go more in favor of abruption. Now, a classical thing that I am sure you all know is when you talk about clinical presentation, DIC, okay, disseminated intravascular coagulation is what you see with abruption. And if I ask you the why, do you remember the why? I'm sure you do, right? So this is release of tissue thromboplastin. है ना? So this is because of release of tissue thromboplastin from the decidua. Okay? Now, if we ask you in terms of bleeding, what amount of bleeding, or rather, what amount of placental separation is linked to DIC or linked to fetal death? So please remember, when separation exceeds 50% of the placenta, so when separation exceeds 50%, this is when there is a high risk of DIC as well as a high risk of fetal death. Okay? So when the separation exceeds 50%, the risk of DIC is very high, the risk of fetal death is very high. Okay? So, in fact, ये एक one-liner हमेशा से exams में आता है. What is the most common cause of DIC in obstetrics? Yes. So what is the most common cause of DIC in obstetrics? And this is actually abruption. है ना? So this is abruption. So let's look at. अच्छा ये मुझे बताओ. Do you know that we are no longer using the PAIDS classification? है ना? So PAIDS classification was an older classification for abruption. We are no longer using it. Now can you tell me, on what basis do we say that it is severe abruption or not? So now we say it is severe abruption. Yes. So, Sandy, अगर blood volume के terms में आएगा ना बेटा, तो भी answer 50% है. So हम बोलते हैं, when the maternal blood volume is lost by 50%, you are likely to see fetal death. वो question आता है with respect to fetal death, Sandy. Right? So if 50% of maternal blood volume is lost, then you are likely to come across fetal death. ठीक है? हाँ जी. So on what basis do we say it is severe abruption now? So अब हम बोलते हैं, if you see more than or equal to one of the following complications, then it is likely to be severe abruption. So what are these? So this could be DIC. This could be maternal shock. Right? Then if the patient went on to have a hysterectomy, history of or bleeding that required blood transfusions, bleeding that became a cause of acute renal failure, right? So if she develops acute renal failure, and with respect to the baby, if you come across non-reassuring FHR, or if you come across fetal death, right? So if you see any one or more of these complications, you say it is severe abruption. So अब it is purely based on the clinical findings of the patient. Okay, so that is what we say as severe abruption. So PAIDS classification is no longer used. It has a historical value. But फिर भी अगर PAIDS classification से पूछा जाए, when did you say that it is type 3? Type 3 was the most severe form, right? So what was the criteria to say that it is type 3? The criteria was maternal shock. So if there is maternal shock, it is type 3. Remember, DIC may or may not be there. Fetal death may or may not be there. A lot of times ये भी होंगे. But if there is maternal shock, that was the defining criteria to say that it is type 3 abruption. What was the defining criteria to say it is type 2? Any evidence of fetal distress. Right? So any evidence of fetal distress led to page 2 or type 2. Yes, in PAIDS classification. Okay. Type 1 was easy. What is type 1? So if there is bleeding and pain but no fetal distress, that is type 1. Yes. And type 0 was, a retrospective diagnosis, which is after delivery. Okay. Yes. So remember these are, this is what we use to classify, right? Type 3, type 2 based on the PAIDS classification. Okay. चलो आगे बढ़ते हैं. So the next question says management of abruption includes all the following except. Yes. So what is the answer? Do you want to do coagulation studies? Yes, right, because of high association with DIC. Augmentation of labor, is it true? Yes, because majority of times generally we say management of abruption is evacuation of uterus, right? So most of the times the management has to be termination of pregnancy. So you can do augmentation of labor if the mother is stable, the baby is stable. Can you do artificial rupture of membranes? Yes. In fact, so answer is actually B. Expectant management if fetus is dead. No. So please remember कि जब हम बोल रहे हैं abruption है और fetus dead है, it usually means severe abruption. Right? I told you it means more than 50% of placental separation is there. A very high chance of DIC is there. So you're not going to do a expectant management after this. Right? Now I want to ask you, why ARM or artificial rupture of membranes is specially given importance in abruption? What is the association? So number one, ARM can confirm diagnosis when there is no concealed hemorrhage. Yes, so you remember कि हमने बोला ultrasound में there is a possibility that there is no RPC and placenta is, let's say, normally attached. So अगर ultrasound findings ऐसे आते हैं that placenta is normally attached, it means it's not placenta previa, but it also says there is no RPC. So अब हमें नहीं पता कि is it still abruption or not. So one of the ways to confirm the diagnosis is to do ARM. And what would you see? You will see blood stained liquor. What is the second important reason? Very good, Priyank. Excellent. The second important reason is a tamponade effect. So what happens is all the liquor leaks out. So walls of the placenta or fetus now starts compressing the placental or placenta and stops further separation. Yes. So temporarily this will stop further separation and reduce the bleeding. Okay. Very good, Priyank. So temporarily it will reduce bleeding and may prevent further separation. And third, it will do a induction or augmentation of labor, because this is what we want. We want a quick delivery. Yes. So those are the three important associations why ARM को बहुत importance दिया जाता है when we talk about abruption. So excellent. ठीक है. So those are very, very important things that we should know when it comes to abruption. Now, let's go further. Okay, let's see if you can answer this. So this is again a previous year NEET SS question that I have taken. Which of the following is most useful in predicting the absence of abruption following trauma? Right? So your patient has undergone trauma, a direct abdomen trauma. So which is most useful in predicting absence of abruption? What would you answer this as? As I said, this is a previous year NEET SS question. So इसको क्या answer करेंगे? What do you think is the best answer? Okay, Sandy. Sandy, मैंने बोला ARM के 3 काम होते हैं in abruption. One, you will confirm the diagnosis, especially if it was not a concealed hemorrhage. Yes. So abruption can be revealed, right? And as a result of which, ultrasound will not be able to confirm the diagnosis. So then what you can do is, you can do ARM and you will see a blood stained liquor which tells you that this is abruption. Second, Sandy, वही था जो आपने बोला. So it can induce labor or it can even augment labor. The third reason is, let's draw a picture and understand this. So if this is the uterus and that's the baby inside and this is the placenta which is separating, जब liquor निकल जाएगा तो क्या होगा? The walls will come close to the baby. Yes, something like this. okay, and the baby is going to exert pressure on the placenta, right? So it exerts pressure, it prevents further separation, and therefore it can reduce the bleeding, right? That was the third use. Okay, Sandy? So, no. So, presence of normal fetal heart tones. Why? It can be still abruption, even if the fetal heart tones are normal, right? So, the best answer here is D. Absence of a tense uterus, right? So, absence of a tense uterus. Please remember, the tense is not simply because of RPC, okay? The reason why the uterus is tense is because of the release of tissue thromboplastin. So, remember that in early stages of abruption, the fetal heart tones can be normal. There may be no vaginal bleeding, and obviously it is not necessary that they are going to be in labor. A lot of times abruption and labor will come together to you, right? So the best answer here is actually absence of a tense and painful uterus. Okay, that becomes the best way to say that, okay, this is not abruption. All right? Okay, for the time being. Chalo, let's go further. Let's look at this. So a woman who presents with antepartum hemorrhage was taken for emergency cesarean for fetal distress. The following is seen intraoperatively. What is the cause of the antepartum hemorrhage? Yes? Now, tell me, what is this image? It's a very characteristic image. What is it? Yes. So this is coevular uterus. So this is coevular uterus. Where, and this happens in what? So this happens in uteroplacental apoplexy, yes, which is the other term we use for abruption, or accidental hemorrhage, right? So these are just the other terms we use. So this is coevular uterus, where there is bleeding in the myometrium. Right, so bleeding in myometrium, and therefore the likely cause is abruption. Now I want to ask you, is coevular uterus an indication for hysterectomy? Is coevular uterus an indication for hysterectomy? Yes or no? The answer is no. Okay, so by itself, coevular is not an indication for hysterectomy. Okay, the second thing I want to ask you, is coevular uterus a risk factor for atonic PPH? Yes or no? Is it a risk factor for atonic PPH? Then the answer is yes. So it is an important thing, you should know this. When we are operating and we come across coevular, you should know that this uterus is very likely to go into atonic PPH, right? So, but if atonic PPH is going to happen, we are going to manage it the way we do. We don't straight away land up doing hysterectomy. Yes, so hysterectomy is the last resort, but you should know that there is a possibility that coevular uterus में आप hysterectomy कर रहे हो. Why? Because it was refractory PPH. It was not responding. So yes, if it doesn't, you might have to do a hysterectomy, but after you do the usual management of PPH. Okay? Okay. Now, let's look at this. So this is again a previous year question of your NEET SS exam. So all are complications of abruption except, what is the answer? That this is an easy one, right? So the answer is C, macrosomia. So macrosomia is not a complication of abruption. So intrauterine fetal death in DIC we've already talked about. PPH also we have talked about. Okay. Now I want to ask you, what is the best indicator of, okay, severe hemorrhage? So whether it is antepartum or it is postpartum, if we have to talk about the best indicator of severe hemorrhage, what would you answer this as? So please remember the key word here is best indicator and severe hemorrhage. क्या होता है? So please remember the best indicator for severe hemorrhage or a hemorrhage which can lead to DIC is what? It is low fibrinogen levels. Okay, so the best indicator of severe hemorrhage is low fibrinogen levels. Can you tell me what is the cutoff we take as low fibrinogen levels? What is the cutoff we take for it? So if the fibrinogen levels are less than 200 milligrams per deciliter, इसका मतलब the pregnant woman has bled quite a lot, right? So मुझे जल्दी से याद करके बता दो, what is normal value of fibrinogen in pregnancy? What is the normal value of fibrinogen in pregnancy? So the normal value in pregnancy is usually between 350 to 600 milligram per deciliter, right? So if it is gone below 200, it is the best indicator for severe hemorrhage. Okay. Acha, fall in blood pressure. Very good, Dipanjali. Yes, अब मुझे बताओ, fall in blood pressure early sign होता है या late sign होता है? So hypotension अगर आपको किसी bleeding patient में मिल रहा है, वो early sign है या late sign है? So this is actually not an early finding. Fall in BP तब होता है when there is significant amount of blood loss. So this is something you will see when up to 25% of blood volume is lost. Okay, so when up to 25% of blood volume is lost, that's when you would come across a fall in blood pressure. So blood pressure या hypotension late findings होते हैं, right? So we shouldn't wait for them to know about whether she is having significant hemorrhage or not. Fibrinogen levels उससे पहले affect हो जाएंगे. In fact, before any other coagulation factors, सबसे पहली चीज जो कम होती है वो fibrinogen levels होते हैं. इसीलिए we call them as the best markers because you are able to pick it up early enough. Okay. Chalo, we will talk more about it as I go further. Okay. So now we are moving on to the other causes of late bleeding in pregnancy. But usse pehle, please remember, whenever you talk about antepartum hemorrhage, बच्चे, placenta previa abruption दो common causes हैं, vasa previa less common है. Can you tell me other causes of APH जो पता होने चाहिए that they are causes of APH? So very, very important. Can cervical ectropion be a cause of antepartum hemorrhage? Yes. Okay. Can cervical cancer be a cause of antepartum hemorrhage? Yes. Now tell me, can uterine rupture be a cause of antepartum hemorrhage? Yes. Yes, so even uterine rupture can be a cause of antepartum hemorrhage. So you have to remember this. Now, अगर मैं अभी आपसे पूछूं what is more common cause of APH? Is it placenta previa or is it abruption? What is more common of the two? Is it placenta previa or is it abruption? So the more common of the two is definitely abruption. ठीक है? Now ये यहाँ पे मैं क्यों बोल रही हूँ? Because a lot of times uterine rupture and abruption are going to be very close DDs, right? So they are going to be very close differential diagnosis. They will present in a same way, which is painful bleeding, right? So even in abruption there is painful bleeding. Who is going to tell me भाई फर्क कैसे या एमसीक्यू में कैसे पिकअप करोगे या पेशेंट में व्हाट इज द बेस्ट वे टू थिंक कि अरे दिस इज लाइकली टू बी रप्चर एंड दिस इज लाइकली टू बी अब्रप्शन? व्हाट आर द की फाइंडिंग्स विच विल हेल्प यू डिफरेंशिएट द टू? सो इन अब्रप्शन ना मोटी मोटी बात क्या है, दोनों में पेनफुल ब्लीडिंग होगा, दोनों में फीटल डिस्ट्रेस होगा. यस, सो दे आर वेरी क्लोज डीडीज. सो बोथ विल हैव फीटल डिस्ट्रेस, both will have painful bleeding. But what helps us is, number one, contour of the uterus. Yes. So when it is a rupture uterus, remember the uterine contour is actually lost. Lekin abruption में, because it is a tense uterus, the contour is very well delineated, right? So contour is lost and it is not a tense uterus. In fact, when there is a rupture, a lot of times you cannot palpate all the boundaries of the uterus. Okay? Then, here, as I said, it is a tense uterus. Very good, Dipanjali, you are right. वो important है, वो PV findings है. मैं PA पे पहले मुझे बताओ. So प्रियांक, ऐसा होता है contraction ना abruption में भी बहुत मुश्किल होती है पता करनी, because the basal tone is high. ठीक है प्रियांक? So contraction खाली से कई बार आप नहीं differentiate कर पाओगे whether it is rupture or abruption. There is no doubt that in rupture we say the contractions are lost. But what I am trying to say is that even in abruption, you may not be able to feel the contraction because the basal tone is high. So जो आपने उससे पहले लिखा वो ज्यादा अच्छा आंसर था प्रियांक. वो क्या था आपने जो लिखा? Fetal parts. Abruption में क्या होता है? Because it is a tense uterus, fetal parts are not easily felt. Yes, so fetal parts are actually not easily felt. Whereas in rupture uterus, what happens is, if it's a complete rupture, the baby is expelled out into the abdominal cavity. And therefore we say fetal parts are more easily felt. Yes, so fetal parts are more easily felt with rupture. And finally, yes, जो हमने बोला कि PV पे finding होगा, मगर वो तभी होता है finding if it is an intrapartum rupture, है ना? That is actually the most specific finding for rupture uterus. So the most specific finding for rupture uterus is loss of station, which obviously will not happen with abruption, है ना? So loss of station will not happen with abruption. And yes, PS is absolutely right. So you have to read the question carefully, because if it's a case of previous cesarean section, you should think more of rupture rather than think of abruption. इसीलिए patient history, subtle details are very important to clinching the diagnosis. So a simple word like she is a case of previous cesarean, which we keep highlighting in the labor wards, is going to make us think more towards rupture than think of abruption. All right? Okay. So now we are somewhat in the middle, and if you all want, we can take a short break. Yes? Can we take a 10 or a 15-minute break, whatever suits you? And we'll definitely finish on time, don't worry. As I said, आज के topic थोड़े आसान वाले हैं, so मुझे कम पढ़ाना है, and you guys already know everything. Back. Thank you Priyank. Okay, let's go on to question number 20. Okay, so this is a question which has been repeatedly coming at both levels, undergrad as well as postgrad levels. So let's look at this. So components of active management of third stage of labor include all except. So what are the components of AMTSL? So what is the answer for this one? So the answer is B. Okay, it is early cord clamping. Remember that the universal guidelines are delayed cord clamping, which is to be done at and beyond 60 seconds. Methergin can be used, syntocinon can be used, and controlled cord traction can be done. Now let's go on to the finer details of this. बहुत बार in the exam they've been asking the same question with modified options. So they keep changing the options. So let me ask you this. If I change the options and then I ask you all are components of active management of third stage of labor except, and I put it as controlled cord traction, then I put early cord clamping, then I put the third option as uterine massage, and then I put the fourth option as oxytocin. Okay, what is the answer now? Right, so what would be the answer now? Ye batao. So what is the problem with this version? The problem with this version is that both these statements are incorrect. है ना? So early cord clamping भी नहीं करते, and very importantly, I hope you remember that routine uterine massage is not recommended. What are we supposed to do instead in AMTSL? So instead in AMTSL, what we are supposed to do is intermittent uterine tone assessment. है ना? So actually में ये करना होता है, routine massage नहीं करना होता है. So now both the statements are false statements, right? But what becomes the best answer? So should we mark early cord clamping or should we mark uterine massage? So whenever there is a confusion between these two options, please stick to early cord clamping, right? So please stick to early cord clamping still. So uterine massage se koi nuksan nahi hai. It's just that you don't need it for all patients because you are giving prophylactic oxytocin, and you would need what? You would need more doctor-patient ratio as well to do a uterine massage for every laboring patient. Right? So nahi, C nahi mark karna hai, isliye bata rahi hu. Still the answer should remain as early cord clamping. ठीक है, अब मुझे ये बताओ, under which conditions do you do delayed cord clamping? Under which conditions do you do early cord clamping? Are there any indications for early cord clamping? So indications for early cord clamping are actually, the best is whenever the newborn baby needs resuscitation. Right? So when the newborn baby needs resuscitation, that's when you do a early cord clamping. Okay? Any other place that you know we would do early cord clamping? Any other place? So what is the cord clamping that we do in HIV positive patients? Yes, so neonatal resuscitation is best. The other answer is when the baby is a known case of heart disease. Right? So if the baby is a known case of heart disease, then again we might do early cord clamping. What do we do in HIV positive patients? So please remember, in HIV positive as well, the recommendation is delayed cord clamping. What is the recommendation in COVID? Although it's hopefully not coming back. But yes, what is the recommendation in COVID? The COVID recommendation is again delayed cord clamping, right? So for COVID also it is delayed cord clamping. Now RH incompatibility bhi ek postgrad level pe acha answer nahi hai. It's a good answer for undergrad but not at the postgrad level. Can you tell me why not, बच्चा? दीपांजलि, RH नेगेटिव बोल रहे हो, अर्ली करेंगे, ये कौन से कंडीशन में एप्लीकेबल है? RH negative in early cord clamping is only useful when she is ICT negative. That means she is not sensitized. Only then there is any role of early clamping. If she is already ICT positive, there is no point of doing an early cord clamping. Yes? So please remember this, कि early clamping जो आप RH negative में बोलते हो, वो एक partially correct answer hai. The answer should be a non-sensitized RH negative pregnancy. ठीक है? So there are very few indications where you do early because it is more harmful. But uterine massage करने से आप कोई harm नहीं करते हो. ठीक है? So if you are getting both the options, you are going to stick to early cord clamping as the best answer. ठीक है? The other things what they keep asking for AMT SL is the drug doses, right? So very often they are going to ask you the drug doses. So quickly, before I go on to the drug dose, let me ask you, can we use Tranexa for AMTSL? So can we use injection Tranexa for AMTSL? So the answer is yes. So Tranexa, I know you all know that it is recommended for PPH management, but it is also recommended for prophylaxis in high risk women. So, you know, when your patient is high risk, you will actually give a combination for prophylaxis. So you can give a combination of oxytocin and Trenexa. You can give a combination of oxytocin plus misoprostol, right? So we generally give combinations when the patient is high risk for postpartum hemorrhage, okay? The third thing I want to ask you is, can we use carboprost for AMTSL? Can we use carboprost for AMTSL? Yes or no? The answer is no. Okay, so carboprost is actually not used for AMTSL. Okay, it is only and only to be used for management of PPH. Okay, only to be used for management of postpartum hemorrhage. नहीं प्रियांक, अर्ली कॉर्ड क्लैंपिंग और एब्रप्शन का कोई लेना देना नहीं है. Okay, you are probably talking about a case where the baby needed resuscitation. So then the indication is resuscitation of the neonate, right? Not abruption. Okay. So carboprost is not used. Then quickly tell me, when we talk about oxytocin, I'm sure you all know that this remains the drug of choice for AMTSL. What is the dose and what is the route? Jaldi jaldi batana hai na? These are very basic things, but they're all being asked in your previous year questions. I have seen that, you know, they are asking these drug doses even at the postgraduate level, right? So what is the drug dose for oxytocin? So it is 10 international units, hai na? And we can give it as IM or we can give it as IV infusion. ठीक है? Please remember, बच्चा, IV bolus नहीं देना है, right? So we are not going to use it as IV bolus. So either you say IV infusion or you say IM. So options which say IV bolus become incorrect options. Okay. Then what is the dose of misoprostol recommended by the WHO? See, AMTSL was originally given by WHO, so we have to follow the WHO guidelines when we talk about AMTSL, right? So what is the dose of misoprostol and the route of misoprostol recommended by WHO? What dose? So please remember, WHO says 600 micrograms and the route is per oral. Okay, so 600 micrograms per oral is what is the WHO recommendation, but per rectal can also be used as an alternative, right? So per rectal can also be used as an alternative. क्या आपको पता है that as per the new PSM program, the WHO is now asking us to distribute misoprostol to these women in their third trimester? Yes? Do you know this? Beta, Dr. Gina, Abhina, we are talking about oxytocin for prophylaxis. ठीक है? हम आप जो डोज बता रहे हो उस पे भी बात करेंगे, and that is for management of PPH. I will give you a question that management में क्या डोज करना है. Then I will talk about dose of oxytocin again. ठीक है? No, Priyank, so बिल्कुल नहीं. ठीक है, एब्रप्शन या वाजा प्रीविया में तो वैसे भी if you know we are going to do a cesarean section. Yes, so anyways there, since it is fetal exsanguination, the reason or the explanation is incorrect. So the reason in vasa previa is again neonatal resuscitation, right? So as I said, just keep in mind that the answer has to be neonatal resuscitation. So if in abruption the baby does not need resuscitation or there was no evidence of distress, there is no need to do an early cord clamping, bacha. Okay? Okay. So remember, as I said, the WHO dose is 600 microgram per oral. But what is latest here? Do you know the latest change? तो WHO ने कुछ 2-3 चीजें लेटेस्ट चेंजेस में डाली हैं. वन ऑफ विच इज डिस्ट्रीब्यूटिंग माइसोप्रोस्टॉल to all pregnant women, and already we have a PSM program which is now asking us to distribute misoprostol tablets. The latest change is also now WHO has given it as a range. So pehle it was a clear cut 600 microgram dose which was a recommendation. Now the latest recommendation by WHO is it can be a range of 400 to 600 micrograms. ठीक है. So this is with respect to misoprostol, right? Quickly tell me symptometrine में क्या होता है? Okay, what is the I would say combination in symptometrine? What do you have? So symptometrine has, yes, 5 international units of oxytocin, and it has 0.5 milligrams of methergin. Yes, so 5 international units oxytocin and 0.5 milligrams of methergin, that is what is symptometrine. And lastly, quickly tell me, carbetocin, can it be used for prophylaxis of PPH? Yes or no? So the answer is yes. So carbetocin can be used for AMTSL, but not carboprost. Okay, so this one can be used for prophylaxis of PPH. So far, carbetocin has not been used or studied in the management of PPH. So abhi tak we have not done any kind of management of PPH studies with carbetocin, but it has definitely been studied for prophylaxis and can be used. Please remember, this is 100 micrograms slow IV over 1 minute. Okay, so 100 micrograms slow IV over 1 minute. The typical difference between carbetocin and oxytocin is that this is a synthetic analog, right? So this one is actually a octapeptide and it has a much longer half-life. What is the half-life of carbetocin? Anybody? Yes, what is the half-life of carbetocin? Anyone? So it has a much longer half-life, which is of 40 minutes. Whereas the half-life of natural oxytocin is only 3 minutes. है ना? So natural oxytocin है 3 minutes. For carbetocin, the half-life is 40 minutes. Right? So remember, it can be used. It is 100 micrograms, slow IV over 1 minute. ठीक है? Perfect. So please remember the components of AMTSL and what are you going to answer, because I've seen repeatedly MCQs even in the SS and FNB exams about components of AMSL. Okay? Chalo, let's move further. So the next question is regarding secondary PPH. Which statement is true? So what is the answer here? Right? So the answer is B. Choriocarcinoma can be a cause. Now, option A is incorrect. Diagnosed when bleeding occurs 72 after delivery. Jaldi mujhe batao, what is the definition of secondary PPH? Beyond 24 hours. Now you will fill in the blank. Up to what time postpartum? So bleeding which happens beyond 24 hours, up to what time postpartum is called as secondary hemorrhage? Up to what time will it be called as secondary hemorrhage? Hanji. So please remember, this is not 6 weeks. Okay? So this is not 6 weeks. It is up to 12 weeks postpartum. Right? So up to 12 weeks postpartum is what is considered a secondary PPH. Then remember, in general, the most common cause of primary PPH is atony, whereas the most common cause of secondary PPH, okay, the most common cause of secondary PPH is actually retained placental tissue. Yes, so it is actually retained placental tissue. So choriocarcinoma can be a cause, but it is not a common cause. Common cause is cervical tears. This is balls. Cervical tear will actually cause a primary PPH. So trauma again usually causes primary PPH. Okay. So trauma again causes primary postpartum hemorrhage. Okay. In fact, the most common cause of primary hemorrhage is atony. The second leading cause is genital tract trauma. और क्लासिकली ये क्वेश्चन ही ऐसे आता है, कैसे? In a postpartum woman, the uterus is well contracted, but she is still having PPH. What is the most likely cause? So if the question says it's a well contracted uterus, so if the question says if it is a well contracted uterus and she is still having postpartum hemorrhage, the likely reason is genital tract trauma. Okay. Alright, so Gina is asking me the onset of action. Gina, I'm going to write it here, bache. So if we talk about onset of action of oxytocin, and I am writing for IM dose as well as IV. So for IM dose, the onset is slightly delayed. It is at 3 minutes. With IV dose, the onset of action is immediate. But out of the two, which one lasts longer? It is actually IM. The effect of IM oxytocin will last for about 3 hours. लेकिन IV का क्या होता है, आप जैसे ही बंद कर दोगे वो खत्म हो जाता है because of the very short half life. ठीक है? So that is the onset of action for oxytocin. Then okay, you have a doubt about methergin. I'll talk about that. Actually, उस पे एक और question भी था, इसलिए मैंने methergin यहाँ discuss नहीं किया. But since you have asked Gina, I will definitely answer your query, beta. So methergin, please remember, is given IM, not IV. It can be given intramyometrial. Okay, so it can be given intramyometrial, but we are generally using it as a IM dose for both management as well as prophylaxis. Okay, so we are not using IV methergins. Okay, so it is IM and it can also be given intramyometrial. The same holds true for carboprost. Carboprost is given IM, but it can also be given intramyometrial. Okay, Gina, so I hope I have answered your query. Okay. Then very common when the patient delivers a congenitally abnormal baby. So no, that's not a cause of secondary PPH. It may again generally cause primary postpartum hemorrhage, right? So remember, for secondary it is usually retained placental tissue. So bits and pieces are what are left behind. Okay. So this was typically to help you with the definition, because otherwise we do it wrong. Okay, let's go on to the next one. Postpartum hemorrhage can occur in all the following conditions except. So this is again very important. One of the things which helps us in preventing PPH is identifying patients with high risk. So it's very essential that we know who is high risk so that we can give more attention to these patients in the postpartum phase. Okay. Now what is the answer here? So fetal macrosomia and polyhydramnios, ये दोनों क्या हैं? They both cause over distension. And whenever there is an over distension, it is more likely to cause atony. For the same reason, multi-fetal pregnancy, okay? So for the same reason, multi-fetal pregnancy is a risk factor for PPH. Abruption. So there are various reasons. I just told you. One reason is it can also cause atony and it will cause coagulation defects. So that is why it is definitely a risk factor for PPH. Please remember, any form of APH becomes a risk factor for PPH. So even placenta previa is a risk factor for postpartum hemorrhage. So yes, the answer here is post-dated pregnancy. Okay. Now let me ask you something, because I somehow see some confusers here. So is preeclampsia a risk factor for PPH? So is preeclampsia a risk factor for postpartum hemorrhage? Yes or no? Yes. So preeclampsia is an important risk factor for postpartum hemorrhage. But does it cause atony? Is the reason or the etiology atony? So no, the etiology here is not atony. It is actually a low platelet count as well as abnormal platelet function as well as a probability of coagulation defect. Right? So yes, it is a risk factor, it is an important risk factor, but the mechanism is not atony, is what I want to bring across. Okay, is diabetes a risk factor? Is diabetes mellitus in pregnancy a risk factor? Yes. So this is also a risk factor. The reason here is usually over distension because of macrosomia, because of polyhydramnios. Okay. What about any form of induced labor or prolonged labor, or extremely short labor like precipitate labor, and abnormal labor like instrumental deliveries? Okay, so please remember this. Any form of induced or prolonged labor, precipitate labor, instrumental deliveries, they are all important risk factors for postpartum hemorrhage. Okay, so they are all important risk factors. Is parity a risk factor? And under what condition we use say it becomes a risk factor? So we say grand multi-para. Okay, so grand multi-para becomes a risk factor for postpartum hemorrhage. Okay, then another confuser they ask is previous history of MRP. What is MRP? Manual removal of placenta. Right, so this is manual removal of placenta. So this is what they ask. Is previous history of MRP a risk factor? The answer is yes. So previous history of MRP is also a risk factor. And remember, MRP karte kiske liye? It is done for retained placenta. Okay, so this is done for retained placenta. Okay, now since I have used the term here, I would really want to know from you, when you talk about retained placenta, we know the possible etiologies can be trapped placenta, or it can be placenta adherence, or it can be PAS. Okay, so these are the three reasons why there will be a retained placenta. I want to know from you, how will you differentiate 1 from 2 and 2 from 3? Chalo, ye bata do. So how will you differentiate trapped placenta from placenta adherence? And how will you differentiate placenta adherence from placenta accreta spectrum? Anyone who wants to highlight how would you answer these questions in case you get them? So please remember, when you say it is a trapped placenta, it means it is separated, but it is not thrown out because of closure of the cervix. So when you say it is trapped placenta, you will see signs and symptoms of placental separation. Yes? So gush of blood, lengthening of cord and so on, right? So you will see signs of placental separation. But when you say placenta adherence, it means that this has not separated. So in both PAS as well as placenta adherence, signs and symptoms of placental separation are absent or are not seen. Okay, so isme signs and symptoms of placental separation will be not seen. Now coming to how will you differentiate 2 from 3? So how you differentiate 1 from 2 and 3 is clear, but how do we differentiate 2 and 3? So I said trapped placenta is because of constriction of the cervix. So the placenta is trapped behind a closed cervix. Right? To differentiate adherence from PAS, this is only possible by MRP. So when you try manual removal, in placenta adherence, plane of separation is easily made out. Right? So when you are going to try manual removal of placenta, if it is adherence, it will be easy for you or your hand to find the plane of separation. Whereas in PAS, there is no plane of separation. Yes? So that's how you differentiate them from each other. और ये बहुत जरूरी है, ये इसलिए जरूरी है क्योंकि तीनों चीजों का मैनेजमेंट ही बिल्कुल अलग है. व्हाट डू यू डू फॉर ट्रैप्ड प्लेसेंटा? यू हैव टू गिव यूट्राइन रिलैक्सेंट्स. What do you do for adherence? You do an MRP. What do you do for PAS? You'll have to do a hysterectomy, right? So it's very essential that we know that retained placenta can be these three things. How will we differentiate them and what would be the management of each of these? Okay? Okay. Perfect. So, let's go further now. Is fibroid uterus a risk factor for PPH? Yes. So I don't think you will do those things wrong. So chorioamnionitis, fibroid uterus, they are going to be risk factors for PPH. Okay. But they are also a lot of times put in the options when they are asking you risk factors. All right. जीना अभी टाइम नहीं होता है बेटा अल्ट्रासाउंड करने का. सो अल्ट्रासाउंड विल नॉट बी एबल टू डिफरेंशिएट द पास एंड adherence. The only way we say you want to differentiate them is when you are trying manual removal. Okay? Okay, let's go further. So now we talk about management. है ना? Atonic PPH is best managed by. So what is the correct option out of these? So atonic PPH is best managed by. So IV bolus oxytocin is always incorrect. Okay, please remember if we are giving oxytocin IV, it has to be a infusion. IV से क्या होगा? High doses IV will cause severe hypotension, which can be severe enough to even cause an MI and a cardiac arrest. ठीक? So never give it as IV bolus. Okay, Priyank is asking me, मैम ग्रैंड मल्टीपैरा किसको बोलते हैं? तो वो लिखने के तरीके पे है बच्चा. So if you say grand multipara, either you say more than 4 or you say more than or equal to 5. तो वो फर्क है. So how you write it makes the difference. So अगर आपको खाली मोर देन में आंसर करना है तो इट इज मोर देन 4, और अगर मोर देन और इक्वल टू में करना है देन इट बिकम्स 5 बच्चा. ठीक है प्रियांक, दैट इज व्हाट इज ग्रैंड मल्टीपैरा. ऑलराइट. सो ऑप्शन ए इज रॉन्ग. व्हाट इज रॉन्ग विद ऑप्शन बी? एवरीथिंग. सो द डोज ऑफ मेथर्जिन इज रॉन्ग. व्हाट इज द डोज ऑफ मेथर्जिन? द डोज ऑफ मेथर्जिन इज 0.2 milligrams. Okay, you don't give it as a 0.5 milligram injection. So, and you don't give it IV. We said we will give it IM. What is wrong with option C? Carboprost, the dose is right. So it is 0.25 milligrams, but again it is never IV. Carboprost has to be given IM. Right? So the only correct option is 20 international units in 500 ml of normal saline, which is given as an IV infusion, and you will do a uterine massage. Now, doses of 20 to 40 international unit are correct. फर्क क्या है? If you give 40 international units, you should make it a solution in 1 liter of normal saline. ठीक है? With lesser doses हम क्या करते हैं? We can make the solution in 500 ml as well, which is what is readily available as a IV vac. So, you can go from 20 international units to 40 international units when it comes to management of PPH. It all depends upon कि आप कितने लीटर में वो infusion बना रहे हो. So if you are giving 40, you should make it in a 1 liter. Please don't put 40 in 500 ml. Okay, so that is the difference. Then, can we make the IV infusion of oxytocin in 5% dextrose? Can we make the oxytocin infusion in 5% dextrose for management of PPH? So please understand this is a big no. Okay, 5% dextrose is a electrolyte deficient media. So अगर आप oxytocin infusion इसमें बनाओगे तो क्या होगा? Water intoxication. So please remember that oxytocin is a is a drug or is a hormone which resembles ADH. Okay, so it resembles anti-diuretic hormone. So it also can cause water intoxication as a side effect. You should know this. So never make it in 5D, make it in RL, make it in NS. Electrolyte deficient में नहीं होना चाहिए. DNS, yes, because then it has D and N also, right? So DNS में बना सकते हो, but not only in dextrose. ठीक है? So those are important things. Now, since we are talking about atonic PPH, what is now the recommendation for Tranexa? Anybody? What is the latest recommendation for Tranexa? Tranexa should be given, okay, to all patients of postpartum hemorrhage. कितने ड्यूरेशन में देना है और कितना डोज देना है आर इंपॉर्टेंट क्वेश्चंस. कितने ड्यूरेशन और कितना डोज? सो प्लीज रिमेंबर, ट्रानेक्सा हम देने वाले हैं 1 ग्राम स्लो आईवी देते हैं ओवर 20 मिनट्स. ठीक है, सो 1 ग्राम स्लो आईवी over 20 minutes. ठीक है? Yes, Priyank, that is what you can give at one time. Okay, so maximum dose is 3 liter. All right. Chalo. So 1 gram IV over a span of 20 minutes is what you give Tranexa as. But what I said is, कितने टाइम में देने में इसका बेनिफिट होता है? Should be given to all patients of PPH within first 3 hours. No benefit has been shown if it is given after 3 hours. So whatever benefit has been shown is only what? Is only if it is given in the first 3 hours. Okay? So 1 gram IV over 20 minutes to be given to all patients of PPH in the first 3 hours is what is the latest recommendation. Right? Now, we have already talked about dose of carboprost, dose of methergin, dose of oxytocin. What is the dose of Mizo in management of PPH? What is the dose of Mizo in management of postpartum hemorrhage? So when it comes to Mizo, the WHO recommendation is 800 micrograms and they say to give it sublingual. What is the alternative? They also say that it can be given per rectal. 800 to 1000 micrograms become the dose for per rectal administration, right? So per rectally you can go up to 1000, but otherwise the WHO recommendation is 800 micrograms sublingual. Okay? So we wanted sublingual here because it is management, so you want a faster action of misoprostol. So that is what is to be preferred, but the alternative is per rectal. Okay? So those are the different drugs that you should know when it comes to management of postpartum hemorrhage. Okay? Chalo. Let's go on to the next one. Now regarding DIC, what statement is true? So can it be seen in intrauterine fetal death? Yes. Okay. So the first statement is true, but let's go on to the other ones. Can cause decrease in fibrinogen degradation products. This is false. देखो fibrinogen कम होता है और fibrinogen degradation products increase होते हैं, right? So degradation products will increase. Again, does it cause a decrease in PT-INR? No, it actually causes a increase in PT-PTTK. Yes, so it causes a increase rather. Characterized by increased platelet count? No. So DIC is consumptive coagulopathy. Right? So the platelets are going to decrease. Now मुझे एक question बताओ, when it comes to intrauterine fetal death, after how much time is there an increased risk of DIC? So risk of DIC or coagulopathy in intrauterine fetal death is, when is it seen? So this risk is increased only if the baby is, dead baby is retained for more than 4 weeks. So if the dead fetus is retained for more than 4 weeks, then there is an increase in the risk of DIC. Okay? Now, remember, when it comes to DIC or coagulopathy, whether it is APH, whether it is PPH, what are our targets? है ना? Targets होते हैं, we have to maintain hemoglobin more than 7.5. Very good, Priyank. Good. Okay. We have to maintain platelet count at more than 50,000. So this might not come as an MCQ, but I think these are very, very important things when it comes to patient management. So yes, you have to know कि हमें transfusion कब तक करना है. Then our target to keep fibrinogen levels to more than 300 milligrams per deciliter. We want to keep PT as well as APTT to less than 1.5 times the control value. Right? So we want to maintain PT and APTT less than 1.5 times the control value. Right? So those are our targets when we are dealing with DIC, whether it is because of APH or whether it is because of PPH. Okay? So you have to keep replacing all the products. Okay. So, clinical presentation of DIC includes all except, what is the answer for this one? This should be easy. So, it is fever. So, because of all these transfusions, there is a risk of rather hypothermia. Right? So, you have to ensure that whatever products you are replacing have a normal temperature. Right? So, the risk with DIC is hypothermia, and in fact उससे क्या होता है, उससे shivering होता है, उससे cardiac load बढ़ता है, and it can actually cause a cardiac arrest. So we have to definitely take care of hypothermia in DIC apart from the other targets that we have told you, right? So here it is going to be fever. Perfect. Let's go further. Okay, let's do this one. So regarding ergometrine to control PPH, so when nothing is written, it means what is true, right? So you have to mark the true statement here. So regarding ergometrine to control PPH, what is the true statement? So is it contraindicated in patients with high BP? Yes. So actually A is the answer. That is what is the true statement. So it is contraindicated in pre-eclampsia and eclampsia. It is also contraindicated in women with heart disease, and it is also contraindicated in women with peripheral vascular disease. Why? Because you know methergin causes what? Severe vasoconstriction. Right? So it causes severe vasoconstriction. So it is A. Can you tell me what is an important contraindication for carboprost? Important contraindication for carboprost. So this is going to be asthma. Okay. Can you tell me an important side effect of misoprost? What is an important side effect of misoprost? So these are the things we are fond of asking when it comes to MCQs. So this is hyperthermia. We say fever with chills. So miso is notorious to do fever with chills or hyperthermia, and it's actually proportional to the dose. Okay? Okay. What is wrong with option B? In fact, methergin acts more on the lower uterine segment. So oxytocin actually acts on both the upper and the lower, but methergin has more action on the lower segment. Yes? Intravenous is the only route to be given, so this is false. What we always generally prefer is IM route for methergin, for the reason because it can cause severe hypertension. Okay? Can it be used for induction of labor? No. So methergin is only and only used when it comes to postpartum hemorrhage prophylaxis or management. We are not using it for induction or augmentation. Take care. Okay. Let's look at this. So a little lamba question, but let's see this. So your patient is 31 weeks with known placenta previa. She continues to bleed heavily, and so because she continues to bleed, the patient is delivered by cesarean section under general anesthesia. The baby and placenta is easily delivered, but the uterus is bogey and atonic despite intravenous pitocin. Which of the following is contraindicated in this patient for the treatment of uterine atony? So ये बहुत आसान है, लंबा सा क्वेश्चन है, मगर otherwise बहुत आसान है. What is the answer? What is the answer? The answer is obviously D. It is terbutaline. Just a moment, please. Right, I'm sorry for that. Yes, so yes, this is an easy one. So all we wanted you to know is different names of different drugs. So please, terbutaline is a tocolytic agent. You're not going to give that for uterine atony. So misoprost, yes, is very often put as cytotic, right? Prostaglandin F2 alpha kya hai? Because that's how they confuse you. What is prostaglandin F2 alpha? So this is same as carboprost. It is also called as hemabate. Okay, it is also called as hemabate. It is also called as dinoprost. Okay, now what is dinoprostone? So prostone is Cervi prime, which is PGE2. Okay, so dinoprostone is PGE2, right? Prost is PGF2 alpha. अब मेरी बात ध्यान से सुनो और मुझे बताओ, can you use Cervi prime, not the gel, okay, but can you, okay, let me simply say, can you use PGE2 for PPH? Yes or no? Can we use prostaglandin E2 for management of PPH? Yes or no? So here also the answer is yes. So you can use a 20 milligram rectal suppository. Okay, so we can use a 20 milligram rectal suppository in place of misoprostol. So अगर misoprostol available नहीं है, we can use PGE2 for management of PPH. But now I'm asking you the reverse. Can you use carboprost for induction of labor? So induction of labor के लिए is where we typically use PGE2. So can we use carboprost for induction of labor? No. Okay, so this is a big no. So carboprost cannot be used for induction. PGE2 can be used for induction and can be used for management of PPH. एक डाइनोप्रोस्ट है, एक डाइनोप्रोस्टोन है, सो गड़बड़ नहीं करना है, ठीक है? ओके, लेट्स गो फर्दर. सो योर पेशेंट इज 30 वीक्स, अगेन अ नोन केस ऑफ प्लासेंटा प्रीविया, ओके, एंड शी इज बीन डिलीवर्ड बाय अ सिजेरियन सेक्शन. अब क्या हो रहा है? The baby is delivered, but placenta is adherent to the uterus and cannot be removed, and heavy bleeding is noted. Okay, so heavy bleeding is noted, which means we are dealing with PAS, right? Which of the following would be the next best step in the management? What is the answer for this one? So I've highlighted. She was a case of placenta previa. She is undergoing a cesarean section. We've delivered the baby, but we can't deliver the placenta, right? So she is bleeding heavily. What is the next best step? यहाँ पे क्या आंसर करना है? So please remember, हमेशा हमने भी सिखाया होगा, आपने खुद भी पढ़ा होगा और देखा भी होगा, that whenever you talk about management of PPH, we always say follow the algorithm, है ना? याद है? ऐसा हम बोलते हैं, follow the algorithm. Do this, then go to this, then go to this, then go to this. This is an exception. Okay? This is an exception. Once you have recognized that it is PAS, you don't go along the algorithm. Algorithm में hysterectomy is the last resort. But remember, for PASS, we break the algorithm and we are going to go ahead with hysterectomy. Yes, so please remember this. Don't say ki I've given oxytocin, now I will give carboprost, then I will do a balloon tamponade, then I will do B-Lynch. So no, so we're not going to follow the algorithm for PASS. We will straight away go on to hysterectomy. Take care. Okay. So let's do this now. A 28-year-old patient complains of amenorrhea after DNC for PPH. What is the most likely diagnosis? Yes, so what is the most likely diagnosis now? So here, जैसे ही हम amenorrhea और PPH पढ़ते हैं, आपके दिमाग में क्या आता है? Sheehan's. मगर यहाँ पे खाली amenorrhea और PPH नहीं पढ़ना. यहाँ पे you have to give attention to the word DNC was done. Right? So this is actually going to be Asherman's. So this is not actually Sheehan's. This is Asherman's. ठीक है? So ध्यान देना है. That is why. And this is a previous year NEET SS question. Right? So this is a previous year NEET SS question. So it's not Sheehan's. Right? It is Asherman's. Okay? Sheehan's में होता तो हम क्या लिखते? I think I have put one question. आएगा आगे. So we will see. Right? Sheehan's में the presentation is completely different. Right? So the most common presentation is actually failure of lactation. And the second most common presentation is what? It's amenorrhea. Now, the difference in Sheehan's is that when we want you to answer it as Sheehan's, we would not really say DNC. Instead, the key word in the MCQ would be severe PPH, which required many units of blood transfusion. So that is the key thing. For Sheehan's, it has to be severe PPH, where many units of blood are given, because that tells you that there is likely what? Pituitary ischemia. So Sheehan's सिर्फ pituitary ischemia में होगा. So not every PPH is causing Sheehan's beta. ठीक है? So to cause Sheehan's, it has to be severe enough in order to cause pituitary ischemia. Remember that whenever we talk about Sheehan's, it is anterior pituitary. The posterior pituitary is spared. So it's the anterior pituitary which is going to be affected. Okay? Alright, let's go further. So, a woman delivers an infant with a midline episiotomy and suffers a 3rd degree tear. And there is a possibility that she is going to bleed from this tear because there are going to be bleeders. So, which of the following structures is intact? So, what is intact if it is a 3rd degree tear? It is the rectal mucosa. Yes, so what is intact is rectal mucosa, because rectal mucosa is a 4th degree perineal tear, right? If the sphincter is torn, then it is a 3rd degree perineal tear. If it's perineal body, that means the muscles, then it is a 2nd degree perineal tear. Okay, do you know the subdivision of 3rd degree? So 3A, 3B and 3C. Right? So 3A is less than 50% of external anal sphincter torn. है ना? B is more than 50% of external sphincter torn. And what is C? C is when both external and internal sphincter are torn. So a lot of times they're asking the classification of perineal tears, and I'm sure you already know it, but just to reinforce that this is asked in the postgrad exams as well. So you should know this. Okay? All right. So let's look at this. An intern is conducting the delivery, observes that the mother is developing breathlessness, hypotension, tachycardia and is collapsing. The shock is out of proportion to bleeding. What is the likely cause? What is the answer for this one? So, a very, very characteristic presentation. So this is, yes, I am sure you all already know this. This is amniotic fluid embolism. So a sudden onset of breathlessness, which rapidly progresses to hypotension, cardiac arrest, and coma is what is amniotic fluid embolism. Shock out of proportion to bleeding. In which other condition would you see this? Uterine inversion. So please remember this. In inversion also, the shock is out of proportion. Okay? Because initially, to begin with, what shock is it? It is neurogenic. So gradually the neurogenic will become hemorrhagic shock, which is what is the cause of death. है ना? So hemorrhagic shock is what is the cause of the death. So even in inversion, the shock is out of proportion. But inversion में ऐसा नहीं होगा that there is breathlessness, then there is hypotension, cardiac arrest. No. So inversion का key word क्या होता है? The key word for inversion is shock immediately after delivery. Okay? So shock immediately after delivery is what is going more in favor of inversion. Now I want to ask you, amniotic fluid embolism, is it more common intrapartum or is it more common postpartum? More common intrapartum or more common postpartum? So please remember, in general, okay, in general, amniotic fluid embolism is actually more common intrapartum, followed by postpartum, right? And when it presents postpartum, if I ask you, can it present as bleeding? Yes. So please remember, in the postpartum phase, you can see this classic presentation, but you should know that it can also present as bleeding. Okay? Why? Because, you know, in amniotic fluid embolism, what eventually happens is, so we say the second phase of amniotic fluid embolism is characterized by DIC. Okay? So the first phase is what is happening here. So hypotension, breathlessness, cardiac arrest, they are all first phase. And most women are actually not going to survive, right? In the second phase is what they will also manifest in DIC. So AFE is also one of the causes of DIC, but it is a rare thing to happen. Yes, so it's a rare thing to happen. Is it a clinical diagnosis or a lab diagnosis? Amniotic fluid embolism, clinical or lab? So please remember two things. It is a clinical diagnosis and it is diagnosis of exclusion. So a lot of times they will say your patient developed shock which is unexplained. So if in the MCQ you see the word unexplained shock, then that is what goes more in favor of what? AFE. So immediate shock goes in favor of inversion. Unexplained shock goes in favor of AFE. And in general, the most common cause of shock in a postpartum patient is what is? PPH. Right? So most common is PPH. Immediate is inversion and unexplained is AFE. ठीक है? चलो आगे बढ़ते हैं. Okay, a patient underwent cesarean section and during the surgery there was a need of doing this step. What is correct about the condition? चलो बताओ. What is the correct statement? The answer is A. So what is this? This is B. Lynch. है ना? So this is B. Lynch. Sutures which you all know are done for atonic PPH. It is a surgical step, so it is obviously done when the conservative medical management fails. So the answer is A, right? which is there must have been a profuse bleeding that could not be controlled by medical management. What is wrong with statement B? We do not use a non-absorbable suture. It has to be absorbable suture. Most commonly we would use which one? Chromic catgut. Right? So it is chromic catgut. It is shaped as B. No, that's not the reason why we call it B. Why do we call it B, by the way? Anybody? Why is it called as B Lynch? Because it is named after the person who had first given it. So it's called as Christopher Balogun Lynch. Yes, so it's named after him, and we use a absorbable suture. The suturing is done after closing the uterus. No, okay. So for this we need the incision because of the way we have to take the suture material. So वो closure के बाद आप नहीं कर सकते, ठीक है? कौन सा वाला है जो आप which compression suture can you use without incising the uterus? So which compression suture does not need an incision? Which one? So typically the Cho square sutures. Yes. So where 4 windows are created, they don't need a uterine incision. So Cho square sutures actually do not need a uterine incision to be done. Okay. Please remember, compression sutures are only and only useful for atonic PPH. They would not be effective for any other form of postpartum hemorrhage, right? So they're only useful for atonic PPH. Don't do B Lynch for PAS, okay? It won't be helpful. Fine? Perfect. Okay. So, which of the following is not used in the treatment of uterine inversion? Which of the following is not used in the treatment of uterine inversion? Anybody? What is the answer for this one? So, the answer is D. Immediately remove placenta if attached. So, that is absolutely wrong. If there is a uterine inversion and the placenta is attached, क्या खास बात है? It should not be removed, right? Placenta is to be removed. Okay, placenta is to be removed only after repositing the uterus. So, some of you said A, and that's incorrect. You do use A. Can you tell me where? So, सबसे पहली चीज ये समझ लो, whenever there is a uterine inversion, initially you have to stop oxytocin. Okay, so very, very classic. The patient might be bleeding, but initially you have to stop oxytocin and you have to do a manual repositioning. Right, the Johnson's method. अब क्या होता है? The manual repositioning may fail and it may become successful. अगर ये सक्सेसफुल हो जाता है, then you now start oxytocin and then remove placenta. मगर अगर the manual repositioning fails, फिर क्या करना है? So the most common reason for failure is a constriction ring. Yes, a contracted uterus which is not, because the lower segment will contract. So you'll not be able to push it back. The cervix will contract. So the most common reason for failure is the constriction ring. So if it fails, this is what you need to do. You need to check the vitals. So vitals can be stable or she may be hemodynamically unstable. If the vitals are stable, then this is where you give tocolytics and you will try manual repositioning again. Is this clear? So tocolytics have a definite role as long as the patient is hemodynamically stable. Okay? But if she is unstable, you have to straight away take her up for a laparotomy, right? So then you will have to straight away take her up for a laparotomy and do the Huntington's procedure. Yes, so that is what we do most commonly at laparotomy. ठीक? Which tocolytic are we using here? So nitroglycerine as well as terbutylene as well as magsulf. ये तीनों use कर सकते हैं. So we can use NTG, we can use terbutylene, and we can use magsulf. Any of these three, but generally the best one is NTG because of the extreme short, short action of the drug. Okay, so this is what you should know for management of uterine inversion after its presentation. Okay? Okay. Right, so this is the question that I was talking about, that I do have one. So which of the following does not occur in postpartum pituitary necrosis? What is the answer here? It's easy. So it cannot be galactorrhea. This is again a previous year NEET SS question. ठीक है, ये भी आपका previous year का question है. So you see signs of hypoglycemia because of adrenal insufficiency, because of lack of ACTH. Asthenia is because of deficiency of growth hormone. Amenorrhea is because of deficiency of LH and FSH. And what you see is failure of lactation because of deficiency of prolactin, right? So you will not see what? Galactorrhea. ठीक है, ये भी previous year का ही question है आपका. Yes, so the answer is not A, बच्चा पार्टी, the answer is C. Okay? चलो, I think सिर्फ थोड़ा ध्यान से पढ़ना है बच्चे MCQs को. Don't hurry up on things, right? Just go a little slow, find the keywords and then think of the answer. Okay? Right. Although majority of times previous LSCS and rupture uterus is more likely to happen when intrapartum or postpartum. Intrapartum. But sometimes there is a rupture uterus postpartum which is presenting as a postpartum hemorrhage as well. Right. So it can present as postpartum hemorrhage as well. But let's look at this. So a 23-year-old patient with previous cesarean is in labor for VBAC. Which of the following conditions is specifically seen in uterine rupture? So we have already discussed this. Loss of station on PV exam is what is the most specific finding. Yes. So there could be other reasons for maternal tachycardia, right? Suprapubic tenderness, you all know, is not the very characteristic sign, but yes, it is also important. Hematuria can happen but may not happen. So it only happens if the tear extends into the bladder wall, right? The other things about rupture uterus as in APH and its DD we have already talked about. So you could very well have questions on antepartum hemorrhage, but it is actually a case of uterine rupture. Okay? Okay. Since, previous cesarean and rupture can often present as APH. That's the reason I wanted you to know a couple of these things. So which of the following is a contraindication for trial of labor after CS? So this is again a previous year question, right? But an easy one. So it is classical cesarean. Please remember, classical cesarean is a absolute contraindication. Can you tell me other absolute contraindications? So other absolute contraindications. So previous history of rupture uterus, right? So history of rupture uterus is an absolute contraindication. More than or equal to 3 previous LSCS is a absolute contraindication. Hysterotomy. Right? So previous hysterotomy is an absolute contraindication. Then if there is a non-reassuring fetal heart rate, right? So non-reassuring FHR. Okay? And then obviously conditions like contracted pelvis, conditions like placenta previa would also become absolute contraindication. So I saw a couple of questions about this in the previous year question, so you should have a fair idea. what are relative contraindications? This is something I want to know. So especially अगर हम लोग एम्स के एग्जाम्स की तैयारी करते हैं, they are fond of asking this. What are relative contraindications for VBAC? Anyone? So macrosomia comes under relative contraindications. Breech presentation, okay, comes under relative contraindications. And the third relative contraindication is post-term pregnancy. Okay, so these are the three relative contraindications for VBAC, while the others were absolute ones. Okay, so as I said, I saw a couple of questions and that's why I thought of discussing it. Okay. Amnio hook may cause all except. So this is again a previous year question. Now amnio hook is used for what? Basically artificial rupture of membranes. Yes, so ARM. So it can cause all except. So can it cause AFE? Yes. Can it cause abruption? Yes. Cord prolapse? Yes. So the answer is B. So it's not going to cause IUGR, right? So again, as I said, is a previous year question. So I thought of including it here as well. So, and I saw it a couple of times being asked. Okay? Yes, perfect. I don't think you need my help on that. Let's look at this. A primi gravida presents at 32 weeks with pain abdomen for 2 hours, vaginal bleeding and decreased fetal movements. She should be managed by. So again, a previous year question. So in the end, I just thought of taking a couple of previous year questions to help you with the process. So what is the answer for this? What are we dealing with? So we are dealing with abruption, right? So there is pain, there is bleeding, and there is fetal distress. So if there is decreased fetal movements, please take it as a sign of fetal distress. Although this could simply be because of increased tone as well. Yes. So agar tone zyada hai, obviously she may not feel the movements. But here you have to take it as a sign of distress, and you should answer it as immediate cesarean. Right? So answer it as immediate cesarean. Okay? So I hope there's no confusion on this. Okay? But I totally agree that decreased fetal movements alone cannot be taken as a sign of distress, because this could simply be because of increased tone. But when you get it as an MCQ, they want to indicate that it is a sign of distress. So an immediate cesarean. Okay? All right. We've already discussed this one, so I am sure you'll be able to give me the answer. Shock out of proportion to amount of bleeding is seen in. So, acute inversion, right? So, where I said the reason of shock is actually initially neurogenic. Gradually, yes, it begins to bleed as well because it will be an atonic uterus. Right, so here this is the best answer. Please don't answer it as retained placenta. ठीक है? ये भी previous year question है, and the answer is not retained placenta. Okay, I just told you retained placenta will either have no bleeding because there will be no signs of placental separation, or you will see signs of placental separation, but it is not going to cause shock out of proportion. Right? So acute inversion is the best answer here. Okay? And that brings us to the last question for the day. All the following are causes of atonic PPH except, again, a previous year question. So that's an easy one. What is the answer for this? So we already discussed the risk factors for atonic PPH. So if it is cervical lacerations, it is genital tract trauma. And if it is trauma, I said usually the uterus would be well contracted. Right? So I said they typically give it like this, that a well contracted uterus and the patient having postpartum hemorrhage, what is the most likely cause? So we are answering it as genital tract trauma. Right? So those were the questions I could get substantially from the topic of bleeding in late pregnancy. But yes, I think we've covered more or less all possible causes of bleeding in late pregnancy. If you have any doubts, you can ask me, or else we are pretty much well in time today for a change to finish our class. So I'm happy to take any doubts that you might have or any other thing that you want to ask. The next class would be on next Wednesday. Most likely Dr. Anil will take, and he will update you with the topic that he is going to cover. But anything else that you want me to answer as a query, or if you want to ask anything, you're more than welcome. And we would be updating the questions of this, and I don't know if Dr. Anil's previous class has been uploaded as the questions. So मैं वो भी check कर लूँगी, and I'll ensure कि हम दोनों के OBS के questions are put up as a test paper as well. Okay, so any doubts, anybody? Otherwise, it's a pleasure to always sit here and learn with you. I always consider this as an opportunity to learn, because I believe that you are very well versed. Your recent passed out postgraduates और third year graduates से ज़्यादा किसी को नहीं आता होता, है ना? So third year graduates, postgraduates से सबको डर लगता है, because all they are doing is studying, है ना? So they know everything. So I actually consider this as an opportunity to learn from you, and it's always a pleasure to be sitting here and teaching. So can we call it a day? So if you don't have any doubts, can we call it a day? Okay, I'm just waiting for you people to agree on a common thing in the chat box, and then you're free to go. Hanji. So there are a lot of modifications of B-Lynch that can be done, right? So since the original B-Lynch needed an incision, there are a lot of modifications that have been given, and transverse B-Lynch is just one of them, right? So jahan pe you can do it without giving an incision on the uterus. Okay, Radhika? So I think that's the first thing Radhika has asked in today's class. Hanji. और कुछ बेटा? Anything else? Anything else that you want me to answer? No, Prakriti, I think it's quite the reverse. मुझे लगता है this is the best time to prepare for NEET SS. अभी कोई gap नहीं आया है आपके exams में और preparation में. So it's a very good time to prepare for your NEET SS. सिर्फ you know what I would suggest is, because you know these NB people keep changing things from one form to another form. They keep changing the pattern. और हमें भी पता है इस बार पहले उन्होंने pattern बदल दिया था. Then they came back to the original pattern. So anyways, the pattern is going to change. So it's still a good idea to have a good overview of everything. Anyways, the ratio is 70-30. तो अभी भी सब कुछ आएगा, but हाँ कुछ चीजें थोड़ी ज्यादा आती हैं. So that is why we covered gynae more in detail, क्योंकि वो ज्यादा आता है, right? But I think even if you manage or able to manage a couple of hours, it should be good enough. And that is why we wanted to launch the program, so that you have some standard guidelines कि आप क्या करने वाले हो. Otherwise, everything is too vast if you have to prepare for exams, है ना? So I think it's a good time and it's not tough at all. It's just that the competition is very high क्योंकि सारे बच्चे बहुत पढ़े लिखे हैं. So I do understand that's tough. Yes, and more importantly, it's the duty. I agree with Prakriti. है ना? तो कोई बात नहीं यार, अगर हम ensure कर रहे हैं कि हम यहाँ क्लास में आ पा रहे हैं, you're going through the points, taking down the points and making one notebook, it should be good enough for your revision close to the exam. है ना? So जो भी हम pointers cover कर रहे हैं, believe me, we are going through all possible previous year papers as well. So एक अलग से कॉपी बना लो यार, मैं ये कहूंगी, ताकि close to the exam you are just focusing on the most high yielding things rather than trying to read everything. है ना? So जब ड्यूटी भी है तो कोशिश करते हैं कि क्लास अटेंड करते हैं या बाद में सुनते हैं, थोड़े से नोट्स बनाते हैं और उसी को पढ़ेंगे क्लोज टू द एग्जाम, है ना? ओके, सो लेट्स सी, वी हैव अनदर माय नाउ इब्राहिम बेटा, वो एक बहुत स्पेसिफिक कंडीशन है. अगर आप देखोगे तो एब्रप्शन में आप वेजाइनल डिलीवरी सिर्फ तब करते हो when there is no evidence of coagulation defect, there is no evidence of fetal distress, the mother is stable, the baby is stable. Yes, और उसमें भी अगर तुमको याद हो, हम बोलते हैं the risk of DIC is proportional to the time she stays in with abruption. So the longer she stays with abruption, the higher is the risk of DIC. और इसीलिए we say if abruption is happening in a patient less than 32 weeks, है ना, तो जाके ये guidelines भी पढ़ना, it is an indication good enough to take the patient up for cesarean. Right? Why? Because at less than 32 weeks, the cervix is not going to respond to your induction. It's going to take a long time. And if she spends a long time with abruption, the risk of DIC keeps increasing. ठीक? So इसीलिए मैंने बोला, when they give it like this, what they want to put across is that it is a sign of fetal distress. ठीक है? So answer it as immediate cesarean. Okay? Okay, just a moment. What just happened to my computer? Okay. Yes, Ibrahim, exactly. That's what I answered. So, beta बहुत simple सी बात है. When it comes to estrogen production, it is taking help from the theca cells, है ना? So, theca cells जो हैं वो androgen बना सकते हैं और granulosa cells जो हैं वो estrogen बना सकते हैं. So, कुछ basic level of production is going to come from the basic hormone levels. See, when you talk about any hormones, just a moment, something has happened to my computer. Right, so when you talk about the hormonal production, okay, I don't know what happened. Okay, so when you talk about the hormone production and we talk about predominant estrogen or predominant progesterone, वो सिर्फ cyclical phase में कौन सा ज्यादा आ रहा है? उससे पहले the basal small amounts of hormones of all types are being produced. ठीक है? So the theca cells are enabling granulosa cells and granulosa cells in turn are enabling the, so it's a combined effort with which they are making the androgens as well as the estrogen. So all three can actually be made by diffusion, right? So precisely when we talk about two-cell, two-gonadotropin theory, that comes in when the cyclical aspects become very strong. So you talk about predominant hormones, मगर उससे पहले कुछ basal level of hormones सबके बनेंगे, ठीक है? हाँ जी, any other doubt? Okay. So I think we'll call it a day. If you have any other doubts, please feel free to ask in the WhatsApp group. है ना? I do understand आप लोग busy हो, so it's difficult to be active on the group. But in case you have any doubts, feel free to ask. I'll be happy to answer. Any queries or any places where you feel the answers could be different or something could be different, let's discuss and you can always use the WhatsApp group. There are some new entries or new students have joined the course. To them also I would request कि अगर आप अभी तक हमारे WhatsApp group में नहीं आए हो, please send me an inbox on Instagram so that I'm able to add you to the WhatsApp group, which we will gradually make more active close to the exam. So now the exam is in January, so we'll try and make you more active in the group and put questions and things for you in the group as well. ठीक है? Chalo. Good night everyone. Take care. Thank you so much. Bye-bye.